بالنسبة لنا إن شاء الله دكتورة هناء الفاضل السعيد. هناء graduate from Khartoum University. ما عايزين نقول تواريخ طبعا يا جماعة مع التحفظ، مش كده هناء؟ She's MRCPCH holder in London, having neonatal fellowship, University of Alberta from Canada. She's consultant working now in King Fahd Medical City, and she's the director of the NRB program in King Fahd Medical City. She's a senior consultant and having a lot of work, interested in teaching, and she will present with us and start with us today. And her first topic will be in the neonatal resuscitation program, NRB. Welcome, Dr. Hannah.
السلام عليكم ورحمة الله. شكرا أحمد، جزاك الله خير. Okay, is my screen clear for everyone?
Yes, it is clear, Hannah. تفضل.
Okay, طيب السلام عليكم. Our topic now will be about neonatal resuscitation, inshallah, and we'll try to go over it in a practical way, and I hope that's going to be beneficial for you in your practical life and in your examinations. The neonatal resuscitation, the NRP is usually, I'm going to go over or will be guided by the American Academy of Pediatrics, NRP. And usually there is the International Liaison Committee on Resuscitation that updates the evidence every 5 years and comes with an update for the recommendations of the neonatal resuscitation. The current resuscitation that people are working on is the 8th edition. However, since the 6th edition, the changes haven't been very major. We will go over the resuscitation based on the 8th edition. Our guideline here would be the 8th edition, inshallah. So the 8th edition has been launched in the year 2020, and many places have started following the guidelines since last year, 2021. So I have broken the algorithm of the 8th edition into steps so that we are going to follow it. We start all the time by antenatal counseling and team briefing and preparing the equipment. So the steps that are done before birth. Usually, you should communicate with the obstetric team to assess the risk factors. You should identify a team leader for your resuscitation team. You should evaluate and anticipate the possible complications and plan how you're going to work through it. Delegate tasks. It's very important for the people who are attending the delivery to have specific tasks. يعني ما ينفع انه فجأة انا هاخد الاير واي، انت هتعمل الكompression، انت هتعمل الاسسمنت. No, we need to be prepared right from the beginning. Try to find somebody to document, because documentation of the events is very important, and gather your equipment and make sure that you have a plan or a way to call extra help. Usually for a normal delivery or for a delivery with no risk factors, so no risk factors, it should be attended by one person who is qualified in providing positive pressure ventilation, and this person should be there just for the soul of the baby, purely for the baby, not to have anything to do with the rest of the team. If there is any added risk factors, you need to have a second resuscitator in the team. If it's a high risk, advanced high risk like prematurity or severe distress, then you need 3 people and one of them should be an intubator. There should always be a qualified person in advanced resuscitation, that is a person who can intubate a baby and who can put umbilical lines or have achieved venous access, who should be in-house. That person should be inside the hospital, should be just reachable by a call. The normal questions that should be asked before birth, these are the questions that are recommended by the NRP. You should know the gestational age of the baby. You should ask about the amniotic fluid, whether it is clear or no. And you should ask for any additional risk factors. On top of that, you should ask about the plan for umbilical cord management. Previously, this question wasn't there in the 7th edition, and the extra question or the 4th question was number of babies, or is it single or multiple. Nowadays, because there is so much on the umbilical cord management and delayed cord clamping, if we find time at the end, we'll talk about it. People are adding this as an extra question to be planned and discussed before the delivery, and the number of babies is going to be under the risk factor. The equipment that we should prepare for the resuscitation, I'm not going to go deeply into each of them, but you need equipment to provide warmth for the baby. The baby needs to be dried and warmed. You need equipment to help you clear the airway. You need to auscultate. You need to be able to ventilate the baby, provide oxygen to the baby. You need to be able to intubate the baby and give the baby medications. So all the equipment are under these tasks. And as we are going through the algorithm, we will talk about the equipment that is needed. Before we go further into the resuscitation, I want to just talk quickly about the transition from intrauterine to extrauterine life. So this is considered one of the most physiologically stressful periods in the human life, because during this time there is cardiorespiratory transitioning, the baby's lungs are opening, the baby's circulation is changing. Previously, the blood was going from the right atrium to the left atrium, bypassing the pulmonary circulation, and the rest of the blood that goes in the right ventricle bypasses the pulmonary circulation through the ductus arteriosus, and the lungs are filled with fluid and non-functioning. So as soon as the baby is born and the baby cries, the lungs are opened up with air and the pulmonary vascular resistance drops and the blood starts to go into the lungs with the oxygen saturations rising. The fetal oxygen level or saturation levels are much lower than the newborn after delivery. So this high oxygen is going to lead to spasm in the ductus arteriosus, and their circulation is going to be transitioning to our normal circulation with the major and minor blood circuits. The babies are separated from the placenta, separated from the mother. They need to achieve their own glucose and metabolic homeostasis. The babies need to achieve their own temperature regulation, and they need to adapt to their new sensory environment. So this is a very stressful period for this baby at birth. The percentage of babies who need resuscitation at birth. Okay, up to 85% of babies, they are going to breathe spontaneously within 10 to 30 seconds without any intervention. An extra 10%, that is going to make it around 95%, will respond to stimulation and drying. Another 5% that brings it to near the 100% will respond to positive pressure ventilation. So if you are going to a delivery and if you are able to provide efficient positive pressure ventilation, that is just by bagging the baby, you are going to be able to support and resuscitate most of the babies. Only 2% of the babies will need intubation, and only 0.1% of the babies will need chest compressions and medications, which means advanced cardiopulmonary resuscitation. This is according to the latest ELCOR study in 2020. So the next step, now we know the physiology at birth, and the next step, once the baby, once we have collected our team and anticipated and assessed our risk factors before the delivery, after birth, the first questions that needs to be explored, 3 questions need to be answered. Does the baby look term? Does the baby have a good tone? Is the baby breathing or crying? If the answer for all of these questions is yes, so a term baby with a good tone and vigorous crying or breathing, well, this baby does not need any intervention. This baby stays with the mother for the initial steps. The initial steps, which are drying the baby and warming the baby and making sure that the airway is open and there are no secretions that needs to be cleared. Baby should not be taken away from the mother. Ideally, baby should be flipped on the chest of the mother for these steps. If any of these answers is no, that is the baby is not term, doesn't have a good tone or not breathing vigorously, then this baby needs to be taken to the warmer, which is prepared in the room for resuscitation for the initial steps. So the initial steps of the NRP are warm, dry, and stimulate the baby. Stimulation of the baby is not by shaking. Stimulating the babies in the NRP is by rubbing the feet and the back gently. Okay, please never shake babies. Position the airway so that it is in the what we call sniffing position so that the airway is open. So avoid hyperextension and avoid hyperflexion. Suction upper airway if needed. That is, not everybody is going to need suction. Only babies with secretions in their airway are going to need suction. So if you look here, you can see the first baby is the baby who is in the correct position with the airway slightly extended. The second baby is flexed, where the airway is going to be closed, and the last baby down here is hyperextended. If you can see, when the baby's neck is flexed in the other picture, the colored one, the top one, the baby's airway is closed and the tongue is coming, obstructing the airway. So we want the baby to be like the lower baby in the colored picture. That is to have the airway open. Clearing the airway, as we said, if needed, we should suction the mouth before the nose. Okay, so M before N in the alphabets, because if there are any secretions in the mouth and if you start sucking, then by suctioning the nose, the stimulation might trigger the baby to take a breath, which might end up in aspiration of the secretions in the mouth. So clear the mouth before the nose. Don't go too deep to avoid vagal stimulation. You might need a bulb suction or a suction catheter with different sizes with a source of suction. That could be either on the wall or a portable. Recommended pressures for suction for premature babies are 60 to 80 millimeters of water, and for term babies is 80 to 100 millimeters of water. All our pressures in the ventilation and respiration are usually in millimeters of water, not mercury. So after we have done the initial steps, dry, warm, stimulate, open airway, clear airway, we're going to evaluate and assess the baby again. If the baby is now improving and breathing on their own, then the baby will not need positive pressure ventilation. So if the baby is apneic or gasping and the heart rate is less than 100, this is an indication for positive pressure ventilation. If no, if the baby is having what we call labored breathing or increased work of breathing with cyanosis, this baby is going to need further help by providing the baby with oxygen plus or minus CPAP, which is continuous positive pressure airway, to help and support with their work of breathing, as long as they are having good respiratory effort. Remember, whenever we are giving oxygen, it has to be guided by pulse oximetry and following the targeted oxygenations. We'll talk about that in a minute. If the baby is not breathing well, that is ineffective breathing, and heart rate less than 100, then this is an indication for positive pressure ventilation, which is bagging. If we're doing positive pressure ventilation, we need to attach the baby to a pulse oximeter, and at this time also the NRP recommends to attach the baby to cardiac monitors. Attaching the saturation monitor, usually it is recommended on the right hand of the baby, and the recommendation is to attach the probe to the hand at the last. So attach it to the monitor, switch it on, and then last thing attach it to the hand. This is going to give you better reading and faster reading. Why do you want it to be on the right side, right wrist or right hand? Because it's going to give us the what we call the pre-ductal saturation. Here we see that the ductus arteriosus is joining the ascending aorta or the aortic branch after the branching of the right brachiocephalic. So this blood is not mixed with any deoxygenated blood, and it is going to be reflecting the oxygenation and the saturation of the blood that is going to the brain. We have to follow what we call it the targeted preductal oxygen saturations, which are the physiological saturations at birth. So if you see at 1 minute, it's 60 to 65%. So a baby has the right to be cyanosed at birth, okay? And they will gradually pick up by the age of 10 minutes, they will be 85 to 95%. It is very important to follow these saturation, targeted saturation, because we do not want to deliver oxygen unnecessarily to the baby, because oxygen is a toxic drug. So indications for PPV are inefficient respirations, which are apnea and gasping, and heart rate less than 100. Please remember heart rate less than 100 with inefficient respiration. You can have a baby who is born vigorous and crying and pink and with a heart rate is 65 or 70. This is a baby, for example, could be with a heart block or a cardiac condition. So the baby has to have inefficient respiration to need PPV. Equipment that is needed for PPV are masks with different sizes to fit the baby's size, a source of PPV, and we'll look at that in a minute, a source of oxygen and air, and a blender to be able to control the FiO2 that is delivered to the baby. The kind of equipment that is used for providing PPV in NRP are either self-inflating bag, and the self-inflating bag needs to be connected to oxygen. It could have a reservoir or an open end. The other one is so this is the one which is on the two ones. Can you see my cursor? Ahmed, يعني رد علي, is my cursor visible on the screen or no? No?
Yes, it's clear.
Yes? Yeah, okay.
Clear.
So thank you. So these are the self-inflating bags. This is a flow inflating bag, and this is what we call the neopuff. I'm not going to go into details of this, but these are the equipment that are used to provide PPV. You will use whatever is available in your hospital. Okay. Practical points for PPV, you need to use the appropriate size mask. An appropriate size mask is a mask that covers the nose and mouth without covering the eyes and without going below the chin. You need to achieve a good seal, and you need to deliver the respiratory rate between 40 to 60 breaths per minute. After 15 seconds of starting PPV, you need to stop and assess. Usually we assess the chest rise, sorry, don't stop. You assess the chest rise, the air entry, and the heart rate. If your PPV is not effective, then you need to start corrective steps by what we call Mr. SOPA, and we're gonna go into that. And you have to keep repeating your corrective steps every 15 seconds if you are not having efficiency in your PPV. Efficiency is chest rise and air entry, okay? After you have achieved effective PPV for 30 seconds, then you are going to assess the heart rate and decide whether the baby needs chest compressions or not. We'll go into that. So effective PPV, there is chest rise, there is air entry in the lungs, and improvement in the heart rate. If you get these signs, it means that your PPV is effective. You don't get it, it means that you need to look into it. So this is a picture that is showing the different sizes of mask. The mask that is in the beginning is the correct size. As we said, it's covering the mouth and nose, all of these two. This is called the anatomic mask, and this is the just round mask. So covering nose and mouth, not going below the chin and not reaching the eye. The mask in the middle is too small, and the mask on the top is too big. We want to avoid the mask covering the eyes to avoid pressure trauma to the eyes. And we want to avoid the mask going below the chin to avoid leak. And if the mask is not covering the mouth and nose properly, there will also be leak and inefficient PPV. To achieve a good seal on the mask, you need to hold it in what we say the C and E. So the C, your thumb and index finger should be holding the mask at the base. Avoid holding the mask at the stem. that's not going to give you a firm grip. And the rest of your 3 fingers will be on the bony part of the mandible. Avoid also bringing your fingers into the soft part of the chin or of the jaw, because you are going to obstruct the airway. So C and E, achieve your C and E holding of the mask. Mr. SOPA are the steps to correct your ventilation. So we said after 15 seconds of starting your PPV, you need to start adjusting. And if it is inefficient, you need to adjust. The first 2 steps that you do are the M and R. The M is to adjust the mask, and the R is to position the airway. You should continue PPV for another 15 seconds. During that time, you'll be assessing for the chest rise, for the air entry. If there is no improvement in your PPV, then you have to do the next 2 steps, which are S and O. Suctioning the mouth and nose. Remember, we said mouth before nose, and opening the mouth. You resume your PPV for another 15 seconds. And if by that time, still you don't have a chest rise, you have to increase your pressure. Usually we set our pressures in the whatever equipment we are using at a PEEP of around 5, and which is the PEEP, which is the positive end, expiratory pressure at 5, and the PEEP, which is the peak inspiratory pressure at around 20 to 25, depending on the size of the baby. So you can increase your PEEP, which is the peak inspiratory pressure. So you increase it by 2 to 3 millimeters of mercury. And if that doesn't work, then after 15 seconds, this is an indication to use an alternative airway, which is either endotracheal intubation or laryngeal mask airway. If you're coming to the endotracheal intubation, the indications of endotracheal intubation in the NRP are to achieve effective positive pressure ventilation. So as the last step of Mr. SOPA, before starting chest compressions, if there's an indication to start chest compressions, then it is recommended to achieve an airway. And this has been a recommendation since the 7th edition. If there is prolonged PPV, if you are able to ventilate the baby by bagging and the baby has improved, however, the baby is not having any spontaneous breathing and the baby, it's taking too long, and more than 6, 7, 8 minutes, and the baby is not responding. The reason could be prematurity. The reason could be the baby might be sick, HIE, septic, hypovolemic. So for these babies, you might need to intubate them. And then remember, when you are intubating a baby, that we think about what we call the DOPS acronym. The DOPS acronym has been added to the NRP during the 7th edition. And it is the way to troubleshoot if you are intubating a baby or after you intubate the baby deteriorates. The D stands for displacement of the tube or dislodging of the tube. The O stands for obstruction of the tube. The P is pneumothorax, which are the very big enemy for us in the NICU. The E is for equipment failure. And the S is for stomach inflation. Sometimes after PPV, if the stomach is too full, then you need to deflate it with an NG tube so that it's not compromising the chest. To decide the endotracheal tube size, it depends on the size of the baby. Most people will go by the weight of the baby. So for the baby who is less than 1 kilogram, extreme preterm baby, usually we use the 2.5 tube. Baby 1 to 2 kilograms, we use the 3. Baby more than 2 kilograms, we use 3.5. And for babies who are 3 kilograms and more, you can use 3.5 or 4. So you just go by these sizes. Nobody is using size 2, okay? It's 2.5. So we use up to 4 in the NICU. To decide the depth of the endotracheal tube, there's a formula that is used, which is the birth weight of the baby in kilograms plus 6 centimeters. So if you have a baby born at 24 weeks who is 0.5 kilograms, that is 500 grams, the endotracheal tube needs to go to a depth of 6 centimeters. That is the old formula up to the 6th edition. In the 7th edition, they added another formula, which is the nasal tragus length, the distance from the tip of the nose to the cartilage in front of the ear, and plus 1 centimeter. So this does not cancel the second one. So both of them are working. For best practice, it is advised to do both of them and find something that is between the two. Equipment that is needed for intubation, you will need a laryngoscope, you need the different sizes of blades, you need power source for the laryngoscope, and you need an extra power source, you need different sizes of endotracheal tubes, you need measure tape, you need a trocar for the endotracheal tube, which is not obligatory. It is up to the person who's doing it. You need the syringe, you need tape, and you need the NG tube. If you need to empty the stomach, we need to auscultate. And this is a laryngeal mask airway. I'm not going to talk about it during this presentation. And you need also a carbon dioxide detector. It could be calorimetric like this one, we'll talk about it, or it could be what we use, the end-tidal, exhaled end-tidal carbon dioxide that is can be detected by some of the monitors. So depending on the facility that you have. When you're using the endotracheal, the introducer or the trocar, please make sure that it does not go beyond the tip of the tube. It is recommended that it should be just above the side holes, because we don't also want it to go above outside the side hole and injure the airway of the baby. Once you have intubated the baby, confirmation of intubation is by looking for chest rise with the bagging, symmetrical air entry in the lungs, air entry in the chest more than the stomach. Make sure you do that, take both of them, because the baby's chest is very small, and the air entry could be conducted to the chest, even if the tube is in the esophagus. You're gonna see mist or moisture in the endotracheal tube. You have to detect the CO2 in the exhaled air. It could be either by the calorimetric CO2 detector, which could be, which is normally purple, and it's gonna change yellow. Please, once you have confirmed that the tube is in, you have to remove this detector, because it increases the dead space during ventilation. Okay, so we have reached the step in the NRP where we have secured the PPV, and we have monitored our air entry with the, monitored our oxygen delivery with the pulse oximetry and the guided saturations. So after achieving that, we need to make sure if the heart rate is still less than 100, you need to see if the baby needs post-resuscitation care or not. Once everything has been achieved and the heart rate is less than 60, so after you achieve 30 seconds of effective ventilation, you cannot do cardiac resuscitation if you have not achieved ventilation. The most important part in the neonatal resuscitation is ventilation, because mostly the baby's issue is ventilation. So if you do not ventilate the baby, you are not going to fix the heart by chest compressions. So after you have achieved ventilation, you give the baby 30 seconds of effective PPV, and then you assess for the heart rate. If the heart rate is less than 60 after effective PPV, then this is an indication to start chest compression. Before you start chest compression, you need to make sure that you have, as we said, achieved an intubation or laryngeal mask airway. You have to put the oxygenation to 100%, and you need to consider putting a UVC at that time, because we are now moving into advanced CPR, cardio-respiratory resuscitation. So you start chest compressions, and the chest compressions, I'm going to go back to chest compressions. Chest compressions, usually you're going to use the 2 thumb techniques. So up to the 6th edition, the method was either the 2 finger or the 2 thumb technique. But from the 7th edition, the recommendation is only to use the 2 thumb technique, because it is more effective in the chest compression, and there is less fatigability of the performer. make sure, as we said, you put in an alternative airway. After 60 seconds, you stop to check the heart rate. In the 6th edition, it was after 45 to 60 seconds. After that, the recommendation was to continue for 60 seconds to allow for more perfusion of the heart. What we are doing during the chest compressions is that we are pumping blood out of the heart and perfusing the heart itself. Because what is happening with the depression of the baby, there is metabolic acidosis, there is decreased perfusion, and the cardiac muscle itself is now depressed and not well perfused. So our primary target is oxygenation of the brain and oxygenation of the heart itself, so that it improves and the cardiac muscle start to pick up, and the heart rate improve and the perfusion improve. As we said, we have to go to 100% oxygen, because at that time the perfusion is so poor that the saturations are not reliable in being followed to deliver the oxygen. The rate is going to be usually 90 compressions to 30 breaths. So usually when we are doing the bagging, there has to be coordination between the person who's doing the bagging and the person who is doing the compressions, so that they work together and count together. So it will be 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and so on. So both of them have to be counting together to achieve coordination. By the compression, you need to put your fingers in a line that is between the nipples and the sternum. So in the middle of the sternum, in the midline, the compression has to be deep enough to compress the chest by 1/3 of the anteroposterior diameter of the chest. And you need to allow for chest recoil so that there will be filling of the heart before you do the next compression. At that time, you need to consider vascular access, which could be either with a UVC or with an intraosseous access. Honestly, it's very, very rare to need to use intraosseous access during a neonatal resuscitation, because at birth, the umbilical cord is fresh and not dried. The anatomy is very easy, and it's very easy to access the UVC and enter inside the umbilical vein and enter inside it. This is a picture that is showing the anatomy of the umbilical cord. It is very, as we said, obvious at the beginning, the 2 arteries and the vein. The vein is single, the arteries are 2, they are smaller in size, they are thick-walled, and the wall usually is in spasm. The artery is thin, patulous, and collapsed. So the introduction of the umbilical catheter will be in the UVC, and after you insert it, you're going to just try to secure it on the abdomen with a clear tape or adhesive tape. There is no need to suture it because it's going to be a temporary line. So the UVC that's inserted during the neonatal resuscitation, it's not going to be deep or central UVC. You usually just want to introduce the line up to 2 to 4 centimeters until you just get good backflow of blood. In case there is an issue with umbilical line, for example, if a baby is having any abnormality of the cord, or if it wasn't easy to do it, then you go into the intraosseous line, which is on the medial side of the greater tuberosity of the tibia. And for neonates, you can use a wide bore needle to just go inside it. You don't have to really have an introducer and everything that is needed for older children or for adults for intraosseous line. Medications are the next step. So after doing chest compressions for 1 minute, 60 seconds, and if the heart rate is still below 60, this is an indication to start to use medications. The medications that are used in the NRP are epinephrine and normal saline. Epinephrine can be used even before you have achieved UVC access or vascular access. The preferred route is IV or intraosseous, but however, if you have completed your 1 minute of chest compression and the heart rate is still below 60 and you don't have a vascular access by that time, then the first dose can go in the endotracheal tube. The ETT dose is 1 ml per kilogram, and the IV or intraosseous dose is 0.2 ml per kilogram. Now, this is a new change for the 8th edition NRP. Previously, The endotracheal dose was 0.5 to 1 ml per kilogram. And the intraosseous or IV was 0.1 to 0.3 ml per kilogram. The new change has been done to just avoid confusion during the preparation of medications and giving orders, and to standardize the care. The normal saline flush that should follow the IV dose is 3 ml of normal saline for all babies, regardless of the size and gestation of the baby. Previously, the normal saline flush was 1 to 2 ml, depending on the size of the baby. This has also been changed in the 8th edition because it was found that you need more normal saline to flush the medicine through the line itself. The epinephrine can be repeated every 3 to 5 minutes, and it is recommended to give a maximum of 3 doses during the resuscitation. The other medication that we use during NRP is normal saline. The dose is 10 ml per kilogram to be given over 5 to 10 minutes. We have to be careful with fluids for premature babies because it can increase the risk for IVH. We need to be more aggressive with fluids for babies that we know are at risk of hypovolemia, like if the mother is having APH, or there is any evidence of antepartum hemorrhage or bleeding, then this is a baby for whom you want to be more aggressive with fluids. So we are going to continue our cycles of resuscitation, chest compressions. Every 1 minute or every 60 seconds, we are going to stop briefly to assess and evaluate the heart rate. If the heart rate becomes more than 60, then we have to stop chest compressions and continue PPV. If the heart rate is below 60, we will continue. Every 3 to 5 minutes, we are going to consider giving another dose of epinephrine, and we can also give, as we said, the normal saline if the baby did not respond to the epinephrine. So the recommendation is to stop resuscitation 20 minutes after birth. Okay, if the baby has no heart rate since birth, then you stop after 20 minutes. And this has also been a change in the 8th edition. Previously, in the 7th edition, it was after 10 to 15 minutes. The 20 minutes have been put in the new NRP because it was found that many people felt that they did not want to stop by 15 minutes, felt that they need to give the baby more time, and again, to also standardize the practice for everyone. This is a very quick summary of the changes of the new, of the 8th edition recommendations in the NRP. First of all, we spoke about the 4 questions, that they removed the question of the number of babies and replaced it by the umbilical cord management. And when we need to use then the initial steps, in the initial steps, what they did in the 8th edition, they changed the language. It's still the same steps, but they just changed the language. They recommended to use cardiac monitors whenever we start to intubate the baby or start to do resuscitation. The doses of the medication and the flush of the normal saline have been changed, and the time when to stop resuscitation has been changed. So these are the changes in the 8th edition NRP. I will go very quickly over some special situations in NRP. Extreme premature babies below 29 weeks. Usually we start the initial FI2 at 30% and continue to monitor pulse oximetry. Remember that for full term.
Sorry, Johanna, you have 5 minutes.
Yes,
so that
I'm following that.
Time for some questions.
Okay. Thermoregulation, babies should be covered with plastic sheet, and we should manage the temperature of the room and put our overhead warmer at maximum. Avoid high inflating pressures, avoid rapid fluid infusions, avoid trundling bear position, which is the legs of the baby being higher than the head, and babies should be handled gently because they have a high risk of intraventricular hemorrhage. Pneumothorax, don't forget pneumothorax during the resuscitation. It's a common complication of positive pressure ventilation. If you are suspecting pneumothorax, please remember to do trans-elimination and to do needle aspiration. Do not wait for X-rays. Pneumothorax is a clinical diagnosis. Pleural effusion could also be part of the complications in NRP, and you might need to aspirate it in babies with hydrops fetalis. Babies with abdominal wall defects, you need to be gentle with them. If you need IV access, then for babies, the first picture here is the gastroschisis and the other one is omphalocele. So you need to be careful. You need to cover the defect with sterile and moist gauze and protect it. Myelomeningocele babies, if you are expecting a baby with myelomeningocele, you need to prepare gauze in a donut shape and soak it or moisturize it with normal saline to make sure that the baby, if you need to put the baby on their back for resuscitation, it's going to protect the defect. Babies with abnormalities in their airway, like Pierre-Robin syndrome, babies with choanal atresia will need oropharyngeal airways to help them breathe. That's it. I will not talk about delayed cord clamping. I will leave time for some questions.
Thank you, Dr. Hana, for this nice presentation. Actually, I'm about to stop you a long time ago, but really I'm interested. I am NRB instructor also, but I'm enjoying listening to the NRB. Thank you, Dr. Hana. I will start with some point. I don't know how to manage even in my unit, Dr. Hana. For me, myself, when I'm going to intubate any baby, and forget to do the nasal tragus length. Usually remember it after intubation because people will be panic in hurry to intubate, baby is desatting or is not improving, so they are intubating the baby quickly. After that, we remember what is the length of the tube. So I don't know how to make it a habit in the unit, so that I can make it fixed, that to measure before intubation.
I think the RTs should be the ones to remind you, because the RT is going to be the one who's assisting the intubator. We use usually the formula, and this, you can do the measurement, nasal tragus plus 1 centimeter, and use the formula. Formula is the weight of the baby plus 6 centimeters. And normally, yes, not weight the babies. In the, by that time, a baby who is born sick, we do not weight them. We just go by estimation.
Yeah.
If you have forgotten to do that, just go by estimation after that and decide the depths of the tube and just go clinically by the air entry.
Okay. Okay. Please, anyone need a question, you can write it in the question answer, please. So we'll wait for that. We have time to answer 3 to 4 questions if possible.
Okay, I have a question here. When should we start NRP for extreme preterm baby, 22, 23, 24? The answer is it depends on your unit and the viability of your unit. What is the success rate for unit? This is a question that should be answered by the facility. إمكانياتكم شنو؟ 23 ويكر هتعمل له resuscitation. يمكن أنت في مستشفى في rural ما حتقدر تعمل له أي حاجة. If you have the facility and the equipment to resuscitate the baby, resuscitate الgestational age اللي عندكم بتعتبروه viable. لكن internationally والstandard is 23 weeks. Babies 23 weeks and above, 23-0 and above are considered viable. 22 plus 6 are not considered viable. Many places عندك 23 to 25 weeks بيعتبروها borderline viability, and some units will go and do prenatal counseling with the family to decide whether to resuscitate the baby or not to resuscitate the baby and make a resuscitation plan for the baby. Lakin by the book, viability 23 weeks and above. Most units in the world who have good NICU technology reset from 23. Rarely 22. I see now in Japan Japanese are restating 22 weekers. Some US centers restate 22 weekers. Some people which are very very precious baby 22 plus 5 or 22 plus 6 لأنك أنت دايما بتخط إنه ممكن يكون في حبة error. إذا البيبي size حقه حلو more than 500 you can try to do that. It depends on your unit وإمكانياتكم. دي أهم حاجة.
بالضبط. Just to add, as Dr. Hana mentioned, that depend on the unit, your facility, and I know a big hospital here in Riyadh, they transferred for me a baby who is just intubated 30 weeks. They said our unit is level 2 and we can deal with 32 weeks and above. So رحم الله امرئ عرف قدر نفسي. فأنت تكون عارف إمكانياتك، حدودك وين. حتى لو أنا كنت بستقبل مثلا small gestation age وجيت إنه السرفايفل ريت بتاعي مش كويس، اليونت بتاعتي collapsing, I have to review, sit with myself, with the team and come down. Okay, let us restate for example 32, start 34, then with the improvement
بالضبط كده على حسب اليونت.
Yes, exactly.
internationally كثير حاجات بسرعة.
طيب اوكي، انا ما ظاهر عندي.
أنا ظاهر شايفة. طيب أول حاجة constant equation for the UVC. في constant equation for the UVC and UAC ممكن أكتبها لكم في الكومنت بعدين، لكن دي ما بنستعملها في ال NRP. NRP low lying UVC 2 to 4 centimeter just enough to get blood back. أول ما جاك blood back طوالي توقف. You don't want it to be central في الدينكافا. You just want it to be تدخلها من الأمبلايكال فين. يا دوب ما دخلت في الدكتس فينوزس. Dose of adrenaline concentration of 1 in 1000. No, the dose of adrenaline should be concentration of 1 in 10,000. اليونتس اللي عندكم الأمبولة اللي فيها 1 in 1000 لازم تحل to dilute it في 10 ml. يعني تجيب الأمبولة اللي فيها 1 ml 1 in 10,000 تجيبها في 10 ml syringe، تاخد عليها 9 ml of normal saline، كده بقت فيه diluted، بقت 1 in 10,000 وبعدين تستعملها. في units عندهم already 1 in 10,000. It's not 1 in 1,000, it's 1 in 10,000. For the NRP, شكرا. Sorry for not mentioning that. Somebody said oropharyngeal airway in a conscious baby. Yes, في الصورة الأخيرة دي هي oropharyngeal airway. You use it in a conscious baby اللي بيكون عنده good ventilation effort، لكن مشكلته في الupper airway زي بتاع الكوينالتريزيا والبيير روبن. Mr. Sofa, at what stage of resuscitation with the positive pressure ventilation when you are not able to achieve effective air entry? So you keep heart rate less than 60 initial step to start chest compression and confused in point of efficient breathing. Please just explain again. Okay, heart rate less than 60 is not an indication to start chest compression until you have achieved air entry. يعني إذا أنت ما قدرت تخلي البيبي ده تفتح رئته وتدخل فيها هواء، ما في فايدة من إنك أنت تعمل chest compression، لأنه البيبي أصلاً مشكلته هي الأكسجينيشن is poor. لو ما حليت المشكلة الأساسية إنك عملت good ventilation, a chest compression is not going to be of any help. Fix this first, oxygenate him, then do chest compression. I hope إنها تكون وضحت. How to manage coiled cord around the neck of the baby. This is a delivery. دي مشكلة الأوبستريشن، ما مشكلتك. الcoiled around the neck دي الأوبستريشن بيطلع.
manage the baby.
ممكن يكفلوا، أنت بيجيبوا لك البيبي، ممكن يجيبوا لك تعبان بعد كده حتكون asphyxiated to resuscitate him، لكن ده ما شغلك أنت، شغل الأوبستريشن. How frequent we can give adrenaline for resuscitation؟ قلنا كل 3 to 5 minutes. If you do it every 3 to 5 minutes دي على ما تصل ل 20 دقيقة حتكون خلصت ال3 دوسز حقتك. Indications for endotracheal surfactant. Yes, intubation could be for surfactant. فزول كاتب هل surfactant indication for endotracheal intubation? It is, but not during NRP. NRP we just want to ventilate the baby and do نعيش البيبي يتنفس وقلبه يضرب. بعد كده this post resuscitation sorry care is البيبي premature. بعد كده في indications معينة وكرايتيريا معينة للsurfactant administration, and for that time you're going to intubate for surfactant. لكن أنا كنت بتكلم عن NRP. NRP it means during the delivery resuscitation. أفتكر كفاية يا محمد، في أسئلة ثانية.
I think we have a lot of questions, but difficult to answer all of it
yes.
now. في ناس بيسألوا من الدوبي وعندنا question بعدين، وأنا حرقت لي بعد الكويشن حاضطر أسحبها لأن شي answered.
ليه ما يرجعوا خلاص هم عارفينها يا أحمد، ليه تحرق لهم؟
اوكي
اوكي. في سؤال والله سؤال مهم، معلش يا محمد، سؤال احمد، سؤال مهم اخير عن الميكونيوم. اسف انا بتكلم عن الميكونيوم هنا. الميكونيوم من السيفنث اديشن you do not have to intubate the baby for meconium. No intubation, just clear the airway زيه زي غيره الميكونيوم. زمان كانت لغايه السكس اديشن لازم انا baby non vigorous baby with meconium you have to intubate the baby and suction for meconium. Okay. I think that will be it for me now يا أحمد. I'll let the next speaker hop in. شكرا لكم.
دقيقة خلي دكتورة هناء you can stop sharing or you have some question. Okay, you can share دكتور عمر now.
ما في داعي للفيديو صح؟ اوكي.
طيب بسم الله الرحمن الرحيم. Our next speaker, the father of the neonatology in Saudi Arabia, دكتور عمر بشير، غني عن التعريف، علم على رأسه نور. He's the head of SAB KSA before, and he's the one of the early people who start جمعية الأطفال بالسعودية، وله يعني مساهمات كبيرة جدا جدا نعجز عن ذكرها، ومن أوائل الناس اللي حملوا لواء وهم السودان وأطفال السودان والتدريب في السودان وشغل كل النيوناتولوجي في السودان. الأب والروحي للنيوناتولوجي، كل ما تستعصى علينا حالة بمرجعنا ومصدرنا دكتور عمر بشير، senior neonatologist in all Saudi Arabia. He's the head of the NICU in Security Forces Hospital. درب وكثير وآلاف من الكونسلتن الآن. كثير من الناس أكيد بيكونوا شافوه في السودان يدرس ويدي محاضرات كثيرة جدا، على تواصل مع المجلس والسفارة والسينيور كونسلتنت في السودان، عشان همه وشغله الشاغل التدريب والتريننج والتحضير والتدريس في السودان، وربط التريني في السودان بالسعودية، وحتى أنه أنا أعرف ساعي في حاجة زي دي. مهما قلت ما حقدر أوفي حقه، مهما قدمته من هنا إلى بكرة حكون مقصر في حق دكتور عمر بشير. Welcome دكتور عمر بشير. He will talk about respiratory stress in the newborn, or as a differential diagnosis approach to the babies with respiratory stress. Welcome دكتور عمر.
شكرا دكتور أحمد. Can you hear me? Can you hear me?
ايوه واضح دكتور عمر واضح.
Thank you very much دكتور أحمد. لا يعني طبعا أحمد عايز يكبرني لكن طبعا ما شاء الله على هذول الشباب إن شاء الله اللي بيحملوا الجهد اللي في المستقبل بإذن الله. طيب أنا I'm not going to waste a lot of time. Respiratory distress in the newborn. طبعا it is an important topic and I don't know طبعا بالنسبة للسودان how can you estimate the incidence بتاعته لكن definitely worldwide it occurs in 7% of all term babies. Here we need to differentiate between preterm and term. I'm going to concentrate first on the term babies. Term babies, they can develop respiratory distress, and even those late preterm babies, they can also have respiratory distress commoner. It is a cause of admission in 15% of term babies and 29% of late preterm babies to the NICU. And now the causes of respiratory distress are well studied, and from that point on, I think people should always take measures to start prevention and treatment so that we can reduce the burden of the disease. Of course, depending on the cause of the respiratory distress, complications may occur, especially if the cause is not treated. For example, if you have got severe group B streptococcal disease, septicemia, and you are not aware of it, that can end lethally or fatally. Right. All right. These are the risk factors for respiratory distress in the newborn: prematurity, meconium-stained amniotic liquor, cesarean section delivery, maternal diabetes, maternal chorioamnionitis, and of course, prenatal ultrasound findings of structural lung abnormalities or oligohydramnios. طبعا now when we are talking about prenatal ultrasound, now this is a practice. And now our practice is to work in close coordination with the fetal-maternal obstetricians, because they can tell us about any antenatal ultrasound findings. Oligohydramnios is well known to be associated with pulmonary hypoplasia. Diaphragmatic can be diagnosed, and hernia can be diagnosed antenatally. And of course, group B streptococcus can be detected in the mother antenatally, either by high vaginal swab culture or these days by a PCR test, that is polymerase chain reaction tests, which we are now using in our hospital. Now, of course, the signs of respiratory distress, and I think also I'm going to stress on the clinical finding, are tachypnea, nasal flaring, grunting, subcostal and intercostal recession and sternal recession, and cyanosis. These are the 5 signs of respiratory distress. Any presence of these signs that makes you say this is respiratory distress. Then, according to the cause, you will say respiratory distress due to pneumonia, due to hyaline membrane disease or surfactant deficiency. Tachypnea, it is the commonest non-specific finding in respiratory, or metabolic or systemic diseases. And it is a compensatory mechanism for high carbon dioxide and for hypoxemia or respiratory and metabolic acidosis. It occurs in conditions of reduced tidal volume, that is especially to achieve sufficient minute ventilation. So you find a low volume or a small volume lung. So this is a significant of tachypnea. It tells you that there is probably respiratory disease, metabolic disease, or systemic disease. And it tells you that there is probably occurrence of hypercarbia or increased carbon dioxide or hypoxia. And as I said, it occurs with conditions of reduced tidal volume. And these طبعا are mainly probably with respiratory distress syndrome. Now, increased work of breathing, and that is, of course, the baby is having a lot of subcostal recession, working hard to try and breathe. And this is usually results from a mismatched pulmonary mechanism, leading to increased airway resistance and decreased lung compliance. And this طبعا occurs mainly in the preterm babies in respiratory distress syndrome. And when the airway is reduced, the resistance increases 16-fold. That is, if the airway is reduced by 50%, the resistance, the pulmonary resistance or the airway resistance increase 16-fold. Nasal flaring, it is a compensatory mechanism that increases the upper airway diameter and reduces resistance and work of breathing, and retractions occur due to poor compliance and high resistance. Again, clinical findings, the significance of respiratory failure. And this occurs because the newborn cannot sustain the work of breathing. It manifests as cyanosis due to hypoxemia or impaired oxygenation, and impaired ventilation due to respiratory acidosis. Right. The pathogenesis of respiratory distress, there are different factors which can lead to that. Alteration during normal lung development, occurring early as in tracheoesophageal fistula, bronchopulmonary sequestration, and bronchogenic cyst. These are all congenital malformations. In late gestation, the parenchymal lung malformation can also lead to respiratory distress. And this includes the CCM is, of course, you know, now the name has changed. It used to be called cystic adenomatoid malformation. As we said, with oligohydramnios, you get pulmonary hypoplasia. CDH is for congenital diaphragmatic hernia. And as I mentioned earlier, severe oligohydramnios will lead to pulmonary hypoplasia. And this is seen mainly in cases of Potter sequence of Potter syndrome, where there is either renal agenesis in Potter syndrome or polycystic disease, where there is sequence, Potter sequence. Right. So these are things which can occur during lung development and lead to a baby to present with respiratory distress. And of course, these are all inherited, or at least these are congenital. Right. There are complications occurring during prenatal or postnatal transition. These include transient tachypnea of the newborn, respiratory distress syndrome, these are mainly in the preterm, pneumonia, meconium aspiration syndrome, and persistent pulmonary hypertension. Right. What are the possibilities of, or the possible differential diagnosis of a baby who is presenting with signs of respiratory distress? As we said, the signs are tachypnea, nasal flare, grunting, subcostal recession, and cyanosis. Right. The differential diagnosis can be an airway obstruction, pulmonary disorders, that is anything in the lung, of course, cardiovascular disease, especially with congenital heart disease, thoracic deformities and abnormalities, and of course, neuromuscular disorders with hypotonia. They can cause respiratory distress, others. So this is a differential diagnosis of any baby who presenting with respiratory distress. Of course, if you are dealing with a preterm baby, especially those who are below 32 weeks, then the most likely cause of respiratory distress in that is because of the prematurity, surfactant deficiency, and respiratory distress syndrome. Right. Just to give you some common case scenarios, a term infant born at 38 weeks after elective cesarean section and had oxygen by nasal cannula and having an abnormal chest X-ray. What are the possibilities? Especially after elective sections, most babies might develop signs of respiratory distress. And that is why now it is agreed that you should not do elective cesarean section before 38 weeks of gestation. It should be around 38, 39, or even 40. It is well known that the removal of the lung fluid is important when, and that is usually what occurs in spontaneous delivery. With cesarean section, that element or factor is not available. So these babies develop mild respiratory distress due to fluid in the lung. And this is what is referred to as transient tachypnea of the newborn. This is because the fluid is not removed from the lung. And this fluid is usually removed by reversal of the chloride and fluid secreting channel in the lungs, epithelium in late gestation. Lung fluid clearance is increased by antenatal steroids, and as I said, fetal thoracic compression during spontaneous delivery with the uterine contraction. And of course, during this stress, adrenaline is liberated from the fetus. How can we prevent transient tachypnea of the newborn? Good control of maternal diabetes. Steroid, I think that is very controversial, although some people have advocated it before elective section. But as I mentioned earlier, the most important thing is to avoid elective cesarean section before 39 weeks of gestation. and to avoid precipitous delivery, fetal distress, and of course, maternal sedation. These are important factors if you want to avoid or to prevent occurrence of transient tachypnea. Transient tachypnea is usually a very mild condition, resolves within few hours or within 24 hours, and usually does not need a lot of interference. Okay, the scenario number 2 is a term baby, spontaneous vaginal delivery. Mother had 24 hours of rupture of membrane. Apgar score was 8 and 8. In the delivery room, they used oxygen, 40% oxygen or FI 2.4, but there was tachypnea, and even with the use of CPAP, the baby was not doing well. So intermittent pressure, positive pressure ventilation was started. So what is the possibility here? Of course, with this history of prolonged rupture of membrane, the baby is exposed to infection. And the diagnosis would be, in that case, is neonatal pneumonia acquired through the transplacental infection from the infected amniotic fluid in cases of PROM, or if the mother has urinary tract infection, and of course also from prematurity. Very important factor is group B streptococcus colonization of the mother. I know you probably don't have the facility of checking for that before delivery of the baby. We are doing that routinely now, as I said earlier on, either by doing high vaginal swab of the mother antenatally, or now by testing the polymerase chain reaction for group B streptococcus or GBS. And this is very important actually if you are going to prevent GBS. The carriage rate of GBS varies from place to place. In our hospital, when we've done a survey some time ago, we found that more than 40% of our mothers were colonized with group B strep. And group B strep can be carried in the anorectum, in the genital vagina, and it can be carried in the nasopharynx. Of course, the other possibility is nosocomial infection. So this is pneumonia and has to be treated. How do you prevent pneumonia in these babies? As I said, GBS screening has to be done for most of the mothers who the obstetricians are following. This has to be arranged with the obstetrician, and that is why these days, I think neonatology is more geared towards the work with the prenatal side, that is with feto-maternal and with obstetrician. I work more with obstetrician than with pediatrician these days, and it is a very important it is a very important step to improve your management in these babies if you have good obstetric care. So you prevent neonatal pneumonia by screening GBS in the mothers. As I said, you can do it by high vaginal swab culture, or these days now, the PCR test is available and it is quick. And then one of the most important things, if these mothers have any infection or PROM or GBS, then they have to be given intrapartum antibiotic prophylaxis 4 hours before the delivery of the baby, 4 hours. In fact, if a mother is a carrier of GBS and she was given the intrapartum means during labor. If it is given before the delivery of the baby by 4 hours, that will prevent infection in those babies. And then those babies who are at high risk, you have to follow them carefully, observing them carefully. Right. How do you manage those babies with risk factors? Those babies who are symptomatic, you have to do full diagnostic evaluation. That is blood culture. Blood culture is the gold standard of detection of sepsis. Blood culture, you can do the markers like blood count, white cell count, CRP, that is C-reactive protein. And these days, we use more of procalcitonin, which is more sensitive than CRP. CRP is better, is useful if you do it, and then you check after 6 to 12 hours to see if it is rising or not. So full diagnostic evaluation. For early onset sepsis, we don't do lumbar puncture unless the blood culture comes positive. And even you don't need to do the urine. The most important, the blood culture. This is for a symptomatic baby. So have to admit the baby, do the necessary investigation, most important blood culture, and start your antibiotics. There is no, you don't give them time until you get results. No, start antibiotics. And if they need support, you support them with either CPAP or mechanical ventilation. If they need other supportive measures for hypotension and so on, you do that. Asymptomatic babies, only limited evaluation. Can do CBC, blood culture, observe the babies because they're asymptomatic, and don't start antibiotics. So this is for pneumonia. Now, the third scenario is if you have a term baby delivered at 41 weeks by cesarean section because the baby is large, but there was thick meconium during delivery, the baby is limp, cyanotic, with little respiratory effort, Apgar was 2 and 7, and the baby had signs of respiratory distress. Saturation of oxygen at 10 to 15 minutes is still 80%. In all babies, by 10 minutes, the saturation, if the baby is okay, should go to above 90%. This baby, until at 15 minutes, the saturation is 80%. And now he's on FiO2 or oxygen concentration of 50%. The baby was started on CPAP, 7 centimeter. The chest X-ray showed infiltrates, hyperinflation. No improvement was seen with CPAP. So the baby was intubated, connected to the ventilator, and inspiratory pressure used was 22 centimeter, which is a little bit high. The oxygen is 60% oxygen is used. Saturation is still low, 80%. The baby was changed to high frequency ventilation, and this baby had an echo which confirmed the presence of persistent pulmonary hypertension. Antibiotics were started. The diagnosis here is meconium aspiration syndrome, and meconium aspiration syndrome is a restrictive disease. Like at the same time, what happens is that the meconium goes to the alveoli and blocks bronchioles, and it creates one-way valve. That is, it distends, but the air doesn't come out. So you get distension, and that will carry the danger of pneumothorax. And this distension, of course, will lead to more hypoxemia and development of persistent pulmonary hypertension. The treatment of meconium, as Dr. Hana was showing earlier on now, It's just suctioning. You don't need to intubate them like what have been described before, but still some of them might go ahead and develop severe respiratory distress due to this meconium aspiration. And as you know, meconium also inhibits the surfactant production, so that would add to the problem. So in a baby with meconium aspiration, you've got distended alveoli, you've got surfactant inactivation, and you have persistent pulmonary hypertension if it goes to the worst. Right. So as I said, this was a baby. I've already said that there is chemical pneumonitis and there is release of cytokines. As I said, it causes partial obstruction with air trapping and hyperaeration. And of course, the result of that would be pneumothorax or air leak. Surfactant is inactivated by meconium and causes more atelectasis with RDS picture. And this profound hypoxemia will be associated with persistent pulmonary hypertension, which sometimes can be very difficult to treat. And how do you prevent meconium aspiration? Is by, if the baby is very depressed and with poor muscle tone and no spontaneous breathing, then you have to intubate. You have to have good obstetric care with good fetal heart monitoring. And in some cases, the obstetricians have been using amnio infusion, although actually it did not reduce the risk of moderate or severe meconium aspiration. As I said earlier, complications of meconium aspiration, the most important is air leak and the persistent pulmonary hypertension. These are the associated with the disorder itself. However, late complications, 50% may develop hyperactive airway disease by age of 6 months, and persistent pulmonary insufficiency may be seen in children up to 8 years of age. Right. Now, of course, respiratory distress syndrome is the disease of prematurity. And nowadays, it is encountered, of course, more in babies who are less than 33, 32 weeks gestation, although it can occur in 34, 35 weeks, or even more than that. And these days, the outcome or the development of RDS, or even, sorry, the treatment of RDS actually starts from the antenatal period. First of all, any preterm, any lady in preterm, especially the one with recurrent abortions or the ones who's having recurrent preterm babies, those babies should have full obstetric evaluation. In centers, they would do cervical length. Short cervix is associated with prematurity. Then to stop the labor, people are using, obstetricians are using progesterone. And as I said, they can use cerclage for cervical shortness. Of course, now there are more and more studies going on the genetic etiology of prematurity. And so far, 6 genes have been discovered associated with the length of gestation and initiation of labor. I'm not going to go into that. Right, so you need to assess those ladies and assess the risk of prematurity. Appropriate maternal transfer to a good perinatal center, and then the use of steroids. Any lady who starts preterm labor or even before, as I said earlier, if you are following those ladies, obstetrician would start thinking about giving antenatal steroids from week 24 and follow these mothers. When they come in labor, yes, they can be given antenatal steroids, and more important these days, if they are below 32 weeks, is to also to give them magnesium sulfate, which is neuroprotective. Delivery room management of preterm babies. It depends on certain factors. First of all, you have to have a lung protection strategies. And that actually is not only for management of RTS, it also for prevention of bronchopulmonary dysplasia, which is a complication of respiratory distress syndrome. So we have to protect the lung from the damage. We start immediately now with CPAP. And as Dr. Hannah has shown, now we are using the T piece, that is of CPAP. We're not using actually the inflating bags anymore. We're using the T piece, and the room in the living room is supplied with puff with that, and we use CPAP mainly for in these cases. We try not to intubate them, because with intubation, you will start the damage of the lung. However, if you happen to intubate them, you have to give surfactant at the same time. Oxygen, with CPAP, you try to reduce the oxygen as much as possible to the lowest. Of course, in preterm babies, they said you start with 30%. If you can come down to room air, that would be fine. And of course, you try to avoid the lung injury. While in the delivery room, you have to make sure that the temperature of the baby doesn't fall. In other words, avoid hypothermia. And then fluid, if necessary. If you want to, if they are not well, you might need to put an umbilical catheter and give them a volume, give them a volume to improve their perfusion. Antibiotics are given to all babies with respiratory distress syndrome because it resembles the GBS pneumonia. Respiratory distress occurs in 80% of babies below 28 weeks of gestation, and for 90% of babies who are 24 weeks gestation. As Dr. Hannah said earlier on, it depends on where you are. Yes, we are now resuscitating babies who are 23 plus weeks gestation, 24 weeks, 25 weeks. We are giving them full support, and the delivery and the resuscitation and the care is attended by a senior person. And the complication of respiratory distress syndrome is bronchopulmonary dysplasia. The problem with respiratory distress syndrome these days is that it is no longer the classical picture of hyaline membrane disease with opacification, airway, bronchogram, and so on. And you might not see them these days because people are using CPAP early and using surfactant early. And we are no longer depending on blood gas analysis. You connect your oximeter and we go by the saturation, keeping the saturation between 90 to 94%. And now with the latest recommendations of the Europeans, the diagnosis is made by assessment of work of breathing and oxygen requirement. In fact, increased work of breathing is an indication to give surfactant. I've already said about the antenatal care, previous preterm birth, short cervix, to use circulage, and for prenatal pre-labor rupture of the membranes, to use antibiotics, antenatal corticosteroids, and then, as I said, magnesium sulfate is neuroprotective. Obstetricians have been using progesterone, and as I said, there are more studies now towards the prevention of prematurity by the genomics, that is, doing the genetic workup. As I said, 6 genes have been discovered. 3 of them are associated with length of gestation, and 3 are associated with initiation of labor. Already I spoke about delayed cord clamping, CPAP, oxygen, a saturation of oxygen, intubation for apneic babies not responding to positive pressure and surfactant, and using of plastic bags for the temperature, avoiding hypothermia. Surfactant therapy is only given as rescue. No longer prophylactic surfactant is advocated because it is associated with more morbidity. You give surfactant only as rescue if there is evidence of respiratory stress, or if there is a preterm baby 23 to 25 weeks. It can be used by intubation. Nowadays, they're introducing fine catheters, given through fine catheters put into the trachea with CPAP. That is called the less invasive surfactant. LISA is less invasive surfactant administration. There are special tubes for that. Well, nebulization, laryngeal mask, I'm not going to talk about that. Surfactant is indicated if a baby is requiring intubation for stabilization. Babies of CPAP of 6 centimeters requiring more than 30% oxygen, and second dose might be required, or third dose if the baby is still requiring high FiO2. The saturation of oxygen targets 90 to 40%. You try not to go above that because it's associated with lung injury, and later on if you carry on retinopathy or prematurity. And keep the alarm limit for your oxygen saturation between 89 to 95%. Non-invasive is preferred to invasive CPAP for risk of babies of RDS, and all CPAP, types of CPAP are the same. Bubble CPAP, BiPAP, CPAP, all of them are the same. And there is no difference between, people say bubble CPAP is better. No, all the studies have shown that there is no difference between them. Synchronized nasal intermittent positive pressure ventilation, that is, if you put CPAP with rate, reduces the extubation failure. And if you can further use high flow nasal cannula, that would avoid more pressure. I think I don't need to go into the ventilation, but in general, if you need to go mechanical ventilation, that is mainly for smaller babies who are less than 28 weeks gestation and who fail to extubation. And we use usually volume targeted ventilation, and the one which we are using is volume guarantee ventilation. High frequency is used, especially in air leaks, and we try to extubate as much as possible early. If extubation trial is used, you can do it when you reach a MAP of 7 to 8 centimeter, or if you are using high frequency, MAP of 9 to 10 centimeter, or even 12 centimeters. I think I don't want to go, these are more complicated, but anyhow, nowadays in neonatology, we use volume targeted ventilation, which has 2 forms. Volume guarantee, which is now used by most people. There's another type called volume targeted, pressure limited, and is limited only in certain places. Usually the babies spend less time on the ventilator. There are fewer air leaks, and the lung injury or the lung-induced ventilator injury is less with volume targeted ventilation. high frequency, I don't want to go into that. Right. Strategies to shorten mechanical ventilation. You can allow the carbon dioxide to go to as much as 60. Caffeine therapy, postnatal steroids to be used if the baby cannot be extubated after 2 weeks or so. Relief of pain and sedation. You need to monitor those babies by pulse oximetry, blood gases, temperature control, and so on. And you need to do serum electrolyte and hematological values and start your nutrition with total parenteral nutrition. Hypotension, use of inotropes, nutrition, TPN or enteral, especially breast milk, and monitoring of the electrolyte and blood glucose. I think I already spoke about the genes and so on. I don't think I need to go more. Finally, one important aspect is congenital diaphragmatic hernia. Of course, nowadays we are privileged by the fact that we have very good fetal obstetricians. They would give us the diagnosis of diaphragmatic hernia antenatally, except on those cases who will come in labor and we don't know about them. But now most of our diaphragmatic hernias are diagnosed antenatally, and we provide we plan their management from the time the case is being discussed. We talk to the parents, we tell them about the risk and the prognosis and morbidity and mortality associated with it. We involve the pediatric surgeons early, and we prepare everything, and we usually deliver them by 36, electively either induction or by elective section at 37 weeks as much as possible. And of course, the senior person has to be around to intubate the baby immediately. You don't bag the babies with diaphragmatic hernias, because that will distend the intestines more and they will go up more in the chest. So the management is all should be planned antenatally. And as soon as the baby is delivered, you have to stabilize, intubate, ventilate, and use as much as possible gentle ventilation, so that you use the minimum pressure to give you a good saturation of oxygen. We accept lower saturation of pre-ductal oxygen of around 90 and post-ductal of 75 to 80. That's acceptable for us. And the use of nitric oxide in case there is pulmonary hypertension. They need supportive care. We do not push them for surgery until the baby is stabilized and the oxygen, the inspired oxygen is minimal, the pressure is minimal, and the baby is very stable. So you can go as long as you can to stabilize the baby, 6, 7 days, 8 days. Don't rush for surgery. In fact, those where the surgery has been done quickly after birth have more morbidity and more mortality. Now, the plan is to stabilize them in the NICU until they reach a situation where the FiO2 is minimal, the pressure is minimal, and all the other parameters and the vital signs are minimal. And then you send them for surgery. Yeah, I think at this point, I think I've taken my hour and I've finished. Thank you very much. If they have got any questions.
For this interesting talk about respiratory stress, I know it needs one day, not one lecture, but we ناخذ الخلاصة والزبدة والخبرات من دكتور عمر. We have few questions, Dr. Omar, that after which CPAP parameters that I can say failure of CPAP, shift from CPAP to mechanical ventilators.
Okay. As I said, you're using CPAP mainly in the preterm baby. طبعا the initial trial of CPAP, which was the COIN trial, اللي بتاعت ناس Kevin Morley, they said they were using CPAP up to 8 or 9. I know if you don't have respiratory therapist and if you are not staying with the baby, a lot of people would be worried to use a CPAP more than 7. So in our unit, we try to go up to 7. If I'm around, yes, I can go up to 8 as long as I'm staying with the baby. But 7 is probably acceptable. And as I said, in the management of respiratory distress syndrome, CPAP 7 and oxygen more than 30% would be an indication for surfactant. Of course, if you are going to give surfactant by endotracheal intubation, probably you will be needing to ventilate that baby. Although if the baby is stable, even if I give surfactant, sometimes I would extubate them and put them back on CPAP because they improve the circulation. But in the tiny babies, especially those who are below 25 weeks, 24, 25 weeks, or even 26 weeks, I think probably those babies will need intubation and and they will need surfactant. And if you're going to intubate them, as I said, you better use volume guarantee ventilation.
Just I want to mention, Dr. Omar, I reached CPAP 9, but that's
You are brave. But you have to be there. Don't leave it.
Yes. And I win now to 7. I win the baby gradually. But starting, I put 9. That chronic lung disease have very bad lung and receive dexamethasone several times and very difficult to wean from the ventilator. The baby self-extubated, so I put on 9.
Yes,
Another
question, I agree with you. If you can use 8 or 9, that's what have been used in the COIN trial by اللي اتعملت في استراليا.
عشان الجماعه اللي معانا you have to be careful of pneumothorax. That's what happened in COIN. They have 9 patients with pneumothorax.
يعني for the boys يعني في السودان who is going to stay with the baby and watch the baby? This is an important point. When I put the baby on CPAP or intubate the baby on ventilation, I don't go away. I stay with the baby until I make sure that the baby is saturating well, blood gas, if there is any carbon dioxide retention is improved, his pH is okay. I don't go away. يعني the problem, okay, and we have taken السبيشاليتي بتاعت النيوناتولوجي بكل المشاكل بتاعتها والمشاق بتاعتها. فلذلك يعني I don't like people, they tell the nursing staff ولا respiratory therapy to put a baby on كده ولا intubate the baby and goes away and just tell them put a pressure of and volume time. No, you have to stay with the baby and make sure that he's saturating well and he's stable, blood pressure is okay. And if you're going to use a CPAP of 8 or 9, then if you're going to stay with the baby, I don't mind that.
Okay. Just again, do we need to put early preterm babies on CPAP even if oxygen saturation is maintained?
Pardon?
Do we need to
I think sometimes you're putting it because of the clinical picture, especially the babies who come to you with term babies or near term with transient tachypnea and so on. Giving them pressure would improve their lung compliance, they improve the oxygenation, and they will distend the alveoli quicker. Yani, I think especially with TTN, it is fluid, but sometimes that helps.
You mean not only the oxygen saturation, we have to look for the work of breathing and the general
Yeah.
condition of the
Exactly. In fact, the European consensus on the management of respiratory distress is mentioning very clearly, for example, the indication for surfactant is, and that is the latest one, which was in 21. There was one in 19, and they revised it in 21. That's the European consensus, which is 10 countries, and they recommend to start, to give surfactant if there is increased work of breathing. So they're not depending only on saturation and CPAP. No, if there is increased work of breathing.
What is the better type of ventilation for RDS due to infant of diabetic mother?
Okay. طبعا the infant of diabetic mother, the problem with the surfactant in infant of diabetic mother is the quality of the surfactant, not just the amount or the quantity of surfactant. But they develop RDS like other babies, and sometimes can be very difficult to treat. Nowadays, I think we opt for volume guarantee, that is volume targeted ventilation. We try to go as much as possible away from pressure controlled ventilation. Why? Because when you are using pressure controlled ventilation, and that was evidence, you do not control the tidal volume. So one of the main reasons for babies to develop bronchopulmonary dysplasia and lung injury is the fluctuations of the pressure causes volumetrauma. That is a fluctuation of the tidal volume in pressure controlled ventilation causes volumetrauma. So now the main reason for BPD is not barotrauma only. No, the most important thing is volumetrauma. And for these reasons, people have shifted to volume targeted ventilation, that is volume guarantee. And the good thing about volume guarantee is that you set a volume. You have a set volume according to the requirement. For a baby, you usually, for very small babies, you probably require about 4 to 5 ml per kg. For babies bigger, you probably use about 3 to 3.5 up to 4 ml per kg. And that volume needs to be delivered by the certain pressure. So you stay with the ventilator, see how much pressure is required to deliver that volume. It is important to look at the PIP and the mean airway pressure. And in fact, this is a good way of weaning those babies. When the mean airway pressure in a volume guarantee ventilation drops to about 7 or 8, that tells you that the baby is ready to come out of the ventilator. And so even infant of diabetics, you try to use volume guarantee. I think it would be better for them. Try not to use pressure controlled ventilation as much as you can, except in diaphragmatic hernia, where we talk about gentle ventilation. It is used in diaphragmatic hernia. And as I said, and that would avoid the ventilator-induced lung injury, mainly volumetrauma in pressure controlled, barotrauma, and then you have the other factors like atelectotrauma, that is because you need sometimes higher pressure to open the lung, and then biotrauma, which is due to inflammatory markers, and the oxidative injury due to increased superoxide and hydroxyl group. That is why you need to keep your saturation low, and you need to.
I think ventilation, the way of ventilation, weaning, and CPAP failure, it needs a separate day with workshop and hands-on work to be more understandable for all people, I think. So at any time, If I know that Dr. Omar Bashir going to Sudan, I will going to announce that, and we can catch him there to give us about ventilation. Again, repeat for us, please, acceptable oxygen saturation in congenital diaphragmatic hernia.
Okay. طيب I've got a special thing about the oxygen saturation. First of all, طبعا let us talk about, they might say not see a lot of diaphragmatic, but talking about the saturation in preterm babies. You know that there have been trials on that. And the last trial was the Canadian trial, or the COT trial. That is Canadian oxygen target trial. And the one before it was a support trial. That is SU for surfactant, PP for positive pressure, O for oxygen target, and trial. The support trial showed that when they were giving oxygen, they had two groups. Oxygen saturation accepted at up to 89, and the second group above 90. And they found that with the ones who were given up to 89, except there was more morbidity and mortality. So that when the Canadian did their trial, they came with a saturation of 90 to 94% in the preterm. Why I'm saying that? Because when we started using that, the ophthalmologist came to me and said, you are having more retinopathy or prematurity now. So now in our unit, we're using 88 to 92%. But if you are asking a question, yes, what is the target for oxygen? Yes, the target is 90 to 94, because this is the latest Canadian or COT trial. And you have to go by the evidence which is available. I cannot say this is what I'm practicing now. Like, you have to go by that. For our boys in Sudan, I think they should not aim at higher oxygen. We know that there's a lot of injuries. Now, coming back to diaphragmatic hernia, yes, now we are accepting lower, and this is, in fact, this was a recommendation by the Canadians, recommendation by the latest European consensus of management of diaphragmatic hernia, which would accept actually even 86 to 88, 89 saturation for oxygen in these babies. Anyhow, I would say for post preductal, for preductal, anyhow, I would go for 90%. And for postductal, ولا بالعكس يا أحمد, probably we're using 75, 80%, accepting that. This is to try to avoid using high pressure, because if you use high pressure, then that might damage the lung more. And this is now people agree that the management of diaphragmatic hernia is gentle ventilation. I know some people are using high frequency oscillatory ventilation, but all the trials have shown that there is no difference between high frequency and gentle ventilation. And of course,
they think, for me, for example, I think that the idea that they think that high frequency is a gentle ventilation, because you are giving a small volume and lower risk to have pneumothoraces and all this. So this is why most people start high frequency in the diaphragmatic hernia.
But there is no evidence that it is better than gentle ventilation. The other thing is there is no evidence that there is a difference between them. Sometimes high frequency, you really need a good setup. Probably I would be okay if I use, and we don't want to go to that, boys, if I use now I'm using high frequency with volume guarantee. It's giving very good results, because with volume guarantee, you are using a very small volume, that is about 1 to 2 ml per kg. But you need experience. you cannot go and leave the baby alone. Most people, they don't know how to use volume guarantee with high frequency.
Yes, I try little one or two case only. We have some question that what about surfactant in preterm baby? And the other question that to use to start with surfactant or caffeine.
Both. Both. Caffeine طبعا. Caffeine was used, the trial for caffeine اللي هي which was the CAP trial was mainly يعني it was for a different reason. But when they did the trial, they found that caffeine improved the respiratory center, improved the stimulation of the respiratory center, improved the contractility of the diaphragm. And in fact, it is a pulmonary dilator. It is probably a diuretic also. And these were 5 things which were found, and hence it was found this way. It was an important factor in prevention or in treatment of bronchopulmonary dysplasia. So now all babies who are less than 33 weeks, I would start them on caffeine, and we start with a loading dose of 20 milligram, followed by a maintenance dose of 10 milligram. And now I use it up to 35 weeks and so on, then stop it. When you stop caffeine, you need to wait for 5 days before you discharge the baby. And so this is for caffeine. All babies, they should receive caffeine. I know.
Really, I face it now. I have extreme preterm who is 25 weeks. Now corrected age, he is 44 weeks, but still needs CPAP as a chronic disease.
Yeah. Oh, this was the problem.
Or you keep to continue.
Yeah, and you better continue caffeine. In fact, the trial on those babies who were sent home without caffeine, they did a trial between the 2 groups. The one group, they gave them oximeters, one group, and the other group were other. But they found that those where the caffeine was stopped, they found that they tend to develop hypoxic episodes at home, which meant that they need caffeine for longer time. You might need caffeine up to 44 weeks post-conceptual, or in some cases up to 52 weeks. فيعني caffeine is there. Surfactant طبعا indication, any baby who is less than probably 25, 24, 26 weeks, I would give them surfactant. Then other than that, rescue surfactant if there is an indication, if he's on CPAP, more than 30% oxygen, or has got increased work of breathing. And really.
أعتقد الأسئلة ما حتنتهي والموضوع شيق والموضوع كبير جدا وطويل including ventilation, surfactant, caffeine, with the medication. It really it is long. I need a lot of.
I don't know whether it will be really relevant to the MD boys.
Use of steroid in RDS. This I think will be the last question, Dr. Omar, because we have. And my announcement for people who please raise their hands. Please write the question, and we are going to read all the questions.
Okay. Yes.
RDS, steroid in RDS.
Right. Okay. Let's say steroid in preterm babies. The evidence now is that you use dexamethasone. Dexamethasone is the one which is used for bronchopulmonary dysplasia. Usually it is used after 14 days or so if the baby is still continuing to be on the ventilator. However, now there are people, there was a trial which have used hydrocortisone from day 2 of prematurity and RDS, and 1 milligram per kg per day for 7 days, 0.5 milligram per kg for 3 days after a total of 10 days. And they found they had good results, but the problem was development of perforation in some of these babies. I think if we, even that, when the trial was done again, I think the perforation was less. So if you are careful, you nowadays in the tiny baby, especially below 26 weeks, 25, in our unit, we started using hydrocortisone from day 2 or day 1 for 10 days. So we are using it. The other trial with, or whether the other thing which is coming through is the use of budesonide, اللي هو inhaled steroid with surfactant at birth. And there are some reports that it is giving good results if you use surfactant with budesonide at birth. Other steroids have been used like prednisolone and so, but the results are not good. The two which are now used, dexamethasone and hydrocortisone.
Okay. Thank you, Dr. Omar Bashir, for this interesting topic. And I know it needs longer time, but because of we have really a long day. Thank you very much for your interesting topic and your talk. Our second speaker, actually, we'll have this lecture. After that, we will have break for break. Our next speaker, Dr. Amira Oshi. Amira Oshi is the neonatology consultant now in Al Hamadi Hospital. She's worked in Security Forces Hospital before. She's Arab board and Saudi board holder. She's our colleague and have interest in neonatology and have a lot of published papers and very active in research. And she is going to talk to us about hypoxic ischemic encephalopathy. Welcome, Dr. Amira. Dr. Omar, you can stop sharing. So that we can allow Amira to share.
Okay.
Okay, you can hear me?
مرحبا أميرة. Welcome, Dr. Amira Oshi.
Okay, Assalamu alaikum wa rahmatullahi ta'ala wa barakatuhu. Thank you, Dr. Ahmed, and thank you for SAB Society for giving me this opportunity to share with you one of the important ethical problems we are facing in our NICUs. I am honored and glad to present with my big boss, Dr. Omar Bashir. أمد الله في عمره وزاده علما ورفعة. Also all the success for our future pediatrician, Sudanese pediatrician, and we are ready anytime if they need any support. Today I am going to present one of the important topics, hypoxic ischemic encephalopathy. I tried to make it more easy and practical. Yes. Yeah. So definition, hypoxic ischemic encephalopathy is a syndrome characterized by clinical and laboratory evidence of acute or subacute brain injury due to asphyxia. The primary cause of this condition are systemic hypoxemia and or reduced cerebral blood flow. Despite major advances in monitoring technology and knowledge of fetal and neonatal pathology, hypoxic ischemic encephalopathy remain a serious condition that causes significant mortality and long-term morbidity. And hypoxic ischemic encephalopathy estimated to cause 23% of all neonatal deaths worldwide, and in the United States, estimated the incidence of hypoxic ischemic encephalopathy is 1 to 4 cases per 1,000 live births. So the pathogenesis of hypoxic ischemic encephalopathy, usually when there is systemic hypoxemia, there is a compensatory mechanism. There will be a peripheral vasoconstriction and redistribution of the blood flow to the vital organs like heart, brain, and the adrenal gland. And this initially will lead to increase in the cerebral blood flow and increase in the blood pressure. With the persistence of hypoxemia, acidosis, and hypercapnia, there will be failure of this compensatory mechanism, and there will be persistent loss of cerebral blood flow autoregulation, and this is lead to reduced blood pressure and reduced cerebral blood flow and ischemic brain injury. When ischemic brain injury happens, there will be a two phase. The first phase is called primary energy failure, and the second phase is called secondary energy failure. Usually the primary energy failure, it occurs in the first 6 hours, and this is the therapeutic window to use therapeutic hypothermia and other modality of treatment for hypoxic ischemic encephalopathy. In the primary energy failure, usually there is deperfusion state and reperfusion state. Initially deperfusion, there is low perfusion. After that will happen the reperfusion. There will be sodium influx and some inflammatory mediator like glutamate, and this is all will lead to necrotic cell in the brain, followed by the reperfusion, which is more dangerous state. In the reperfusion state, there will be more inflammatory cytokines and free radical release. There will be calcium influx, so nitric oxide, and this remain up to 6 hours. After 6 hours, the secondary energy failure between 6 and 24 hours, and this is in the delayed stage where there is programmed cell death and apoptosis and permanent brain damage, and this is the mechanism for hypoxic ischemic brain injury. What is the criteria to diagnose hypoxic ischemic encephalopathy? So we have to have evidence of metabolic acidosis, arterial core blood gas or first hour blood gas pH less than 7, and base deficit equal or more than 16, and in some reference equal or more than 12. Early onset encephalopathy fitting Thompson criteria in babies equal or more than 36-week gestation. How to categorize hypoxic ischemic encephalopathy? So after the insult, we have mild, moderate, and severe hypoxic ischemic encephalopathy. And this is by Sarnat or Thompson scoring. Sarnat scoring, we have grade 1, mild hypoxic ischemic encephalopathy. There is we will assess the alertness of the baby, muscle tone, seizure, activity, pupils, and respiration, and the duration of the insult. So if the baby initially hyper alert with normal or increased tone slightly, no seizure, the pupil is dilated, reactive, and the baby has regular respiration, this goes with mild, but the baby needs continuous assessment because mild also can progress to moderate or severe. And if it is mild, usually this symptom will resolve by 24 hours of age. In moderate hypoxic ischemic insult, the baby will be lethargic, hypotonic, has seizure, frequent seizure, the pupil will be small and reactive, and the respiration will be periodic, and this stage will last from 2 to 14 days. In severe, from the start, the baby will be comatose, flaccid, and can have seizure, or sometimes there is subclinical seizure, cannot seen clinically, but if you connect those babies to alpha integrated EEG, you will see seizure activities. And the pupil will be variable, fixed. The baby will have apnea and might need respiratory support, and this stage will stay for weeks. Thompson scoring, and also from 0 to 3, a score usually up to 22. If the infant score 1 to 10 had mild hypoxic ischemic encephalopathy, 11 to 14 have moderate, and 15 to 22. And usually Thompson scoring is more of prognostic tool, and tool also to tell you whether to start hypothermia treatment or no. So if everything is normal, this is 0. If the baby hyper alert, stare, has seizure less than 3 per day, feasting, cycling, diminished reflexes, more or partial, poor grasp, sucking, respiration, the baby is hyperventilated, Fontaine is full or 10, so you will give 1, 1, 1, then you calculate the numbers. And in stage 2, if the tone is hypo, lethargic, the baby has more or 3 seizure, strong distal flexion, absent moro, absent grasp, absent sucking, reflex, and the baby has brief apneas or need more respiratory support, so this is stage 2. Flaccid, comatose, decerebrate, ventilation, negative, intermittent positive ventilation, this goes with stage 3. So sign and symptom, as I mentioned, if the baby decrease muscle tone and increase deep tendon reflexes, maybe brisked during the first few days, the baby has transient behavioral abnormality such as poor feeding, irritable, excessive crying, or sleepiness, and this is typically resolved within 24 hours. So by assessment, our baby and the baby did not progress further, this most likely mild symptoms. If the infant lethargic, significant hypotonia, diminished deep tendon reflexes, grasp more, as I mentioned, sucking, and sluggish movement, then the baby may experience periodic breathing, apnea, convulsion for the first 24 hours. With full recovery within 1 to 2 weeks, this baby most possibly had moderate insult. In case of severe hypoxic ischemic encephalopathy, from the beginning, the baby will be severely affected, will be comatose, flaccid, and he had seizure. The seizure can be delayed and severe and maybe resist to anticonvulsant treatment. And this seizure, usually it will be generalized most of the time, and their frequency increase usually within 24, 48 hours. You need to start more than one anticonvulsant. And as the injury progresses, seizure might subside, but this is not a good sign because the baby will have like what is called pulse suppression, electroencephalogram, flat EEG, and this is bad sign. At that time, the baby level of consciousness also will be affected, fontanelle will be bulged, and this will suggest cerebral edema. Other symptoms include stupor. The baby will be stupor or comatose, and the breathing may be irregular. The baby might need mechanical ventilation, depressed deep tendon reflexes. All the primitive neonatal reflexes will be absent or decreased, and especially the eye movement. The baby might have nystagmus, gaze deviation, pupil may be dilated, fixed, and poorly reactive to light, and irregularity of the heart. So they have autonomic dysfunction, irregular heart rate, blood pressure instability. So after the baby fulfill criteria of hypoxic ischemic encephalopathy and we diagnose them, the American Academy of Pediatrics and the American Obstetrical College of Obstetrics and Gynecology and for hypoxic ischemic encephalopathy, they put following criteria to say this patient had perinatal asphyxia severe enough to result in acute neurological injury, because we cannot say all babies is severe. So from the beginning, if the baby had profound metabolic or mixed acidemia, pH less than 7 in the umbilical artery blood sample, and persistence of an Apgar score of 0 to 3 for longer than 5 minutes, neonatal neurological sequelae like seizure, coma, hypotonia, multiple organ involvement, kidney, lung, liver, heart, intestine. So this goes with severe insult. Laboratory studies we need to do for them after we admit those babies. We have to monitor their serum electrolyte, renal function, cardiac and liver enzyme to check the magnitude of the affection, CBK, preferably CKBB. It will reflect the brain activity, coagulation profile, including prothrombin time, partial thromboplastin time, fibrinogen level, and arterial blood gas definitely. Blood gas monitoring used to assess the acid-base status and to avoid also hyperoxia and hypoxia, as well as hypercapnia and hypocapnia. So the imaging studies recommended in case of neonatal encephalopathy, MRI, magnetic resonance imaging, and I'm going to talk when is the best time to do the MRI, cranial ultrasound. It is a bedside and useful tool. You can start it initially when your baby is critically ill on mechanical ventilation, no access to do the MRI. Just cranial ultrasound can tell you, will give you some hint if there is cerebral edema, cerebral hemorrhage, like initial tool till you do the MRI. Also, we need to do sometime echocardiography if the patient require high ventilatory setting, high oxygen, to check whether there is persistent pulmonary hypertension, so can be treated appropriately. We need to do EEG, and the standard is the alpha integrated EEG if it is available in our setting. So you can start it immediately within the first hour after admission to the NICU. And later on, we need to do, if the baby survived, we need to do hearing test, because there is increased incidence of deafness found among infants with hypoxic ischemic encephalopathy who's required mechanical ventilation. Also need to check the retinal and ophthalmology later. So the management mainly supportive treatment, initially management following initial resuscitation and stabilization. Treatment, as I mentioned, is supportive and should focus on the following. Very important, adequate ventilation and avoidance of hypoxemia and hyperoxia, as I mentioned, adequate perfusion and blood pressure management. And the studies indicate that a mean blood pressure above 35 to 40 millimeter mercury is necessary to avoid decreased cerebral perfusion. And careful fluid management, control of brain edema, avoidance of hypoglycemia and hyperglycemia, avoidance of hyperthermia more than 37, and hypothermia less than 33 centigrade, and hyperthermia has been shown to be associated with increased risk of adverse outcome in neonates with moderate to severe hypoxic ischemic encephalopathy. Of course, treatment of seizure, and the therapeutic hypothermia decrease the baby temperature from 33 to 33.5 for 72 hours, and followed by a slow and controlled rewarming for infant with moderate to severe hypoxic ischemic encephalopathy. So hypothermia is recommended as a standard treatment for babies with moderate to severe hypoxic ischemic encephalopathy. What about the area where there is low income resources and low-tech therapeutic hypothermia will be applied? What is low-tech therapeutic or passive hypothermia? It is cooling used by passive cooling, so you can off the resus or incubator temperature. You use ice bag, you can use gloves or plastic, clean, sterile. You put cold water or ice and put it in certain area like axilla, groin, and monitor your baby temperature if you have rectal probe. If rectal probe is not available, axillary temperature can be monitored. And don't lower your temperature less than 33. At any time your temperature came less than 33, you can stop the cooling and you rewarm your baby slowly by opening the resus temperature. And it will work, and it found that it is equivalent to therapeutic hypothermia by using total body cooling by machines. In this study, therapeutic hypothermia for neonates with hypoxic ischemic encephalopathy, actually the therapeutic hypothermia is started as a standard of care since 2002, and with the ongoing study, it is recommended, and since that time, it is being a standard of care. In this study, published in 2016, the conclusion that all newborn at equal or more than 36 weeks of gestation with evolving moderate to severe hypoxic ischemic encephalopathy should be treated with therapeutic hypothermia. And therapeutic hypothermia should be performed within 6 hours of birth and should maintain a core body temperature 33.5 to 34.5 for 72 hours, followed by rewarming at a rate of equal or less than 0.5 centigrade per hour. And any baby sustained hypoxic ischemic encephalopathy, of course, need multidisciplinary team care, and we are going to mention that one. And all the treated patients should be followed longitudinally. So as I mentioned, therapeutic hypothermia is a standard care for moderate and severe hypoxic ischemic encephalopathy. What about mild hypoxic ischemic encephalopathy? So for the last year, now there is many experimental study talking about whether to cool babies with mild hypoxic ischemic encephalopathy. Actually, they found that in experimental animal, it worked, but we have to be careful because it is still not standard of care, and we need still more randomized controlled trials to use therapeutic hypothermia in mild hypoxic encephalopathy. But sometimes it is an institutional decision. Sometimes you have gray cases, not moderate, not mild. In gray cases, yeah, sometimes by institutional decision, they are cooling mild cases, but we have also to be medico-legally carefully because it is not yet a standard of care. In this study published in 2013, they tested some babies with moderate, mild, and severe encephalopathy, and those who did not receive hypothermia, and they found that 20% they have abnormal outcome. That is why now some center recommended to perform hypothermia for mild hypoxic ischemic encephalopathy. So criteria for whole body cooling. So any baby moderate or severe encephalopathy, I will cool them? No. So babies, we should perform total body cooling if the baby gestational age is 36 weeks. If the baby less than that, from 35 to 33, it is a consultant decision. Sometimes the baby 33, 34, but by assessment, the baby might be more than that, more than 2 kilos. So hypothermia can be offered, but should be a consultant decision, because hypothermia also, it is not a very safe, and it has its side effect. The weight should be more than 1.8 kg, and post-delivery age should be 36 hours. If the baby passes the first 6 hours, as we mentioned, the baby goes into secondary energy failure, no hope and no benefit. Although now there is some studies going, they are testing whether to cool the babies after 6 hours, whether to cool the babies premature, but still there is no recommendation yet. Acidosis, so we should have the pH evidence of hypoxic ischemic insult, and we have to have a pH cord or first hour blood gas pH 7 less than 7, and basic CES minus or equal 16 millimole. And or if this criteria is not all fulfilled, 10-minute Apgar score less than equal 5, or as the baby require assisted mechanical ventilation more than 10 minutes, and acute perinatal events. So usually in most of the cases, sometimes the cause is not clear, but in most of the cases the obstetrician will call you, there is cord prolapse, abruption placentae, severe fetal bradycardia, which reflected, you can assess it in the CTG later. And so if the baby fulfill any one of these criteria, the baby is eligible to receive hypothermia. And if the cord blood gas is not available, both these criteria should be present. Early onset moderate to severe neonatal encephalopathy, which is confirmed by the Thompson scoring, and Thompson scoring less than 7. What is the exclusion criteria? Whom we should exclude? Birth weight less than 1.8, gestational age less than 36 weeks, age more than 6 hours post-delivery, life-threatening abnormalities if the patient has severe cardiac problem, respiratory problem, life-threatening coagulopathy, major congenital anomalies, and if the death appears inevitable. So the cooling procedure, I will go quickly. So neonate should be, if the baby is eligible for hypothermia, the baby still is within the first 6 hours, we'll place them in a switched off warmer, and the cooling machine should be prepared, and the baby placed in the cooling device. So most of the center, in our center, alhamdulillah, we have our total body cooling device. So we'll place the baby. Previously there is selective head cooling, but now now most of the centers, they have the total body cooling. The study shows the selective body cooling, selective head cooling, and total body cooling is equivalent. So what is available in your center, you can use. Document the time of initiation of whole body cooling and start by 0 hour. And you should have rectal probe temperature monitoring. So if your baby is having imperforate anus, this is contraindication to start cooling, because you need to have the rectal probe with the machine, cooling machine. Probe is inserted approximately 5 centimeters deep. Temperature monitoring should be continuous and recorded every 15 minutes. Temperature target, as I mentioned, 33 to 34, and the aim to achieve target temperature within 1 hour. Cooling period will continue for 72 hours. Pre and postductal saturation should be measured. Saturation should be kept 90 to 95 in preterm, up to 93 is acceptable. Positioning is done at least every 6 hours. So to avoid cold injury and ulcer, better to have central venous access, UVC or PICC line or UAC. And sedation, painkiller, usually we are using a small dose of morphine or sometimes paracetamol infusion. And we have to attach the alpha integrated EEG within the first 1 hour if we have it. And also sometimes the baby will need some support with inotropic support, so we can start a small dose of inotropic support. What is the possible side effect of whole body cooling? So it is a cooling, it is hypothermia, sinus bradycardia is expected, decreased electrolyte imbalance, magnesium, sodium, potassium level, hypoglycemia, platelet dysfunction, coagulation abnormality, arrhythmias, and increase in blood viscosity. When we need to discontinue the whole body cooling procedure, if the neonate has persistent hypoxemia, although the baby on 100% oxygen, no response, and the baby very bad and persistently hypoxemic, uncontrolled bleeding occur, or presence of arrhythmias requiring medical treatment, sustained bradycardia less than 70 beats per minute with hypotension, although the baby on inotropic support. We finish our cooling for our baby for 72 hours. So we will come to the rewarming procedure. Rewarming procedure, gradually increase temperature for the neonate. Our targeted temperature is 36.5. We will rewarm the baby by a maximum, so we can rewarm the baby from 0.3 to 0.5, but usually we are using maximum of 0.5 per hour. Rewarming continue approximately 6, minimum is 6 hours and maximum is 12 hours. Actually, the machine, the total body cooling, the Ticotherm is very smart machine. Once you connect your rectal probe, you put your baby inside, you put the machine on, it will do the job. And it will work and stop according to the situation of the baby, and the rewarming state also, it will be also done automatically from the machine. So possible side effect during rewarming procedure: increased heart rate, decreased blood pressure due to vasodilatation, decreased urine output, electrolyte imbalance due to rate change in renal clearance. So what is the important is the monitoring during whole body cooling and rewarming and post rewarming procedure, very important. So you have to have a clever, smart nurse sitting beside your baby and do the job. So we have to provide continuous monitoring, heart rate, respiratory rate, autosat, blood pressure, so invasive monitoring if possible, temperature, urine output, and perfusion. So they have chart special for that. They monitor vital sign initially every 15 minutes during the first 4 hours of cooling, then every 1 hour up to 72 hours, then during rewarming every 15 minutes for the first 2 hours of rewarming procedure, then every 1 hour up to the rewarming procedure is completed. What is the laboratory investigation we should do during whole body cooling and rewarming phase? So 0 hour, once we put our baby in the cooling machine, we start our cooling. We'll take baseline CBC differential, electrolyte, especially calcium, magnesium, glucose, very important, creatinine, lactate, coagulation profile, and liver function test, blood gas, and cardiac enzyme, plus minus. And some center, they are not doing cardiac enzyme. During cooling, we have to do blood gas every 6 hours for 72 hours or every 8 hours, according to the physician decision. CBC and differential daily for 72 hours because those babies are labeled for thrombocytopenia, leukopenia, electrolyte, calcium, magnesium, glucose, creatinine every 12 hours, coagulation profile every 12 hours twice. And if initially normal, you can make it once per day. And liver function test daily, we have to monitor it. We have to cover our babies with antibiotic because we don't know what is sometimes the cause of the depression, maybe sepsis, maybe other cause. So we have to take blood culture, CBC differential, CRB, procalcitonin, although it might come with this hypoxia, false positive, but still we need to do them and start antibiotic. We'll start ampicillin, cefotaxime. We avoid nephrotoxic medication because these babies, they are jeopardized and they are asphyxiated, and we should be started as soon as possible. Fluid and electrolyte acid-base balance, as I mentioned, we have to avoid hypoglycemia, perform early serum blood glucose level. We accept glucose level from 4.2 to 5.6 millimole per deciliter. Hypoglycemia need to be treated aggressively because we are doing volume restriction for these babies. We are giving them around 50 to 60, sometimes even 40 ml per kg per day. So sometimes we need to use high concentrated oxygen. We can reach up to D15 if we have central venous access. We have to correct the acidosis, very important, because hypercarbia and acidosis more brain damage. With appropriate ventilatory support, we have to support them with ventilator, and it is possible to correct the acidosis. And we should, as much as we can, we should avoid soda bicarb unless it is severely persistent acidosis and needed, and better to be also as a consultant or senior decision, because we know more alkalosis, more cerebral ischemia, and more damage. Volume restriction, as I mentioned, 50 to 60 ml per kg per day till we have good urine output. Then after that, we can assess our baby and increase the fluid accordingly. We have to monitor the sodium. They are prone to siada and hyponatremia. And as we mentioned before, in the pathophysiology, there will be sodium influx, edema, and hyponatremia. Once renal function is established, sodium and potassium can be added, and we have to check the fluid balance regularly with the electrolyte. We should avoid calcium. As I mentioned before, in the pathophysiology, there will be influx of calcium, and the calcium will lead to, there is suppression of the potassium sodium channel, and with the calcium influx, and this will lead to energy failure. So we need not to add calcium unless the baby has calcium less than 1.7 millimole per liter or the baby symptomatic. In each case of hypoxic ischemic encephalopathy, especially moderate and severe, we have to involve the neurology, and especially if there is convulsion. Magnetic resonance imaging should be done in, as I mentioned, especially in cases of moderate to severe, and a better time to do it is 5 to 7 days of age. Especially nowadays, most of the neurologists, they are recommended is in the first 3 to 4 days. And as we know, more than 7 days, the MRI will be normalized. So very important in the initial few days, but sometimes if you don't have MRI compatible ventilator and you cannot do the MRI, so you are stuck. MRI it carry prognostic factors and medical legal issue. EEG also should be considered in the presence of moderate to severe hypoxic ischemic encephalopathy. Anticonvulsant therapy usually is preferable to start by phenobarb as first line. If the baby did not respond, phenytoin, clonazepam, topiramate, and according to the neurology advice. If there is any coagulation profile, so we have to monitor it. Sometimes we need to give extra dose of vitamin K, fresh frozen plasma, platelet, according to the result of the coagulation and the CBC. So we don't usually feed babies during the cooling till we finish the rewarming phase, because there will be decreased blood supply to the gut, and those babies, they are prone to have neck. Although now there is some studies talking about feeding babies during cooling, especially if the baby not on inotropic support and the baby vitally and laboratory wise was stable. But still we are practicing not to feed these babies till we finish the 72 hours, and after rewarming we will assess them, and preferable to start gradually and to start by breast milk. So what is the future prospects? There is many medication actually was studied in the treatment in conjunction with hypothermia. Like erythropoietin, as an example, erythropoietin, they found that erythropoietin had neuroprotective properties in animal model, and for hypoxic ischemic brain injury and neonatal stroke. High doses of erythropoietin, both in conjunction with hypothermia as monotherapy, have been shown promising in preliminary randomized trial for reducing brain injury and improve motor outcome. Actually tried before for some of our patients, but we didn't observe like good outcome, because we tried mainly in those with severe encephalopathy, and some centers they are using erythropoietin. Other medication like melatonin, allopurinol, topiramate, N-acetylcysteine, xenon had been tried, but all still experimental studies, and the latest is still stem cell therapy. And in some center now, studies is going about cord milking as part of stem cell therapy. And the result is promising, but still in experimental phase. The prognosis: most infant with mild encephalopathy develop normally, while infant with moderate to severe encephalopathy are more likely to develop long-term neurological morbidity. Severe brain MRI abnormality from the beginning are usually associated with marked electroencephalographic EEG abnormality and poor outcome. And permanent neurological sequelae can be mild, such as specific learning difficulty or attention deficit disorder, or may be severe and disabling, such as cerebral palsy, epilepsy, visual impairment, and severe cognitive and developmental disorder. Actually, in our hospital, and always we have argument with the obstetrician. They are telling, oh, my baby now at time of discharge, the baby is perfect, he's normal tone, normal reflexes, sucking. So what is the message usually we are giving to them? Don't tell now, because these babies need long-term. Actual, the recommendation now is to follow these babies up to 10 years of age. Previously 7 years, now up to 10 years of age. Sometimes these babies, they have learning difficulty when enter school. Some of them, they have ADHD, and sometimes they have minor disability, but we cannot say my baby normal at time of discharge. Even severe insults, they can be at time of discharge, they can be normal. Morbidity and mortality from hypoxic ischemic encephalopathy. In severe HIE, the mortality rate is reported to be up to 25 to 50%. Most deaths occur in the first days after birth due to multiple organ failure. And some infants with severe neurological disability die in their infancy from either aspiration pneumonia or systemic infection. And the incidence of long-term complication depends on the severity of HIE. As many as 80% of infants who survive severe HIE develop serious complication. 10 to 20% develop moderate serious disability, and as many as 10% are healthy. And among infants who survive moderate hypoxic ischemic encephalopathy, 30 to 50% may have serious long-term complication, and 10 to 20 have minor neurological morbidity. And infants with mild hypoxic ischemic encephalopathy tend to be free from serious CNS complications. So this figure is important when counseling parents and obstetrician. In this study published in 2012, the outcome following hypoxic ischemic encephalopathy overall, and the outcome mostly depends on the HIE grading. They found that this occur in 11%, cerebral palsy 28.3%, learning deficit in 29.7%, epilepsy 11%, hearing loss 10%, and visual loss 12%, and behavioral difficulty 13%. So this is the main problem facing babies diagnosed as hypoxic ischemic encephalopathy. The ethical dilemma is that very important, direct and timely communication between the medical team and the neonatal family, essential because sometimes you need to share decision between the family and the physician. And usually when you face a case of hypoxic ischemic encephalopathy, especially moderate to severe, you need multidisciplinary team, neonatologist, neurology, social worker, social support. So you need to sit with the family, especially when there is decision whether to stop the support and to put the patient as DNR. And very important, and the way how to communicate with those family and to break the news is very, very, very crucial and essential. And you have to avoid targeting your baby sustained asphyxia during labor. So they will suit the obstetrician and they will put the main blame and the court and the problem we are facing. So that is why you have to select the word, you have to talk with the family nicely and put them in the picture from the beginning and try to assure them as much as you can and explain to them in a scientific way. So this baby, Alicia, she sustained severe hypoxic ischemic encephalopathy. She is, comatose, NGT feeding, excessive secretion, need frequent suction, chest physiotherapy continuously. So this type of babies, the one doesn't like to see them in our NICUs, and inshallah will not see them. This is my reference, and thank you for listening. Any question?
Thank you دكتورة أميرة. Really to be honest أحسن لي أشوف 10 diaphragmatic hernia ولا يجيني وحدة شعية. صراحة أكثر حاجة من الدياجنوزيس الواحد اللي ما بيحب يشوفها أبدا لصعوبة الحالات بعدين لما تشوف الأهل منزعجين على طفلهم لما تشوف البيبي سيزنج بالذات السيفير كيسز. عشان كده أول ما يكلمون الدليفري روم عن حالات معينة بصراحة مرات أفضل إني أمشي وأنزل بنفسي للدليفري روم. لما يقول لي في ميكونيوم، لما يقول لي في كورد برولابس، لما يقول لك في ما عارف ترونوت ولا there is no fetal heart detected أو severe bradycardia. فدي حاجات اللي بتخليك أنت انتسيبيت إنه يكون في اتش اي. فدي بصراحة بتخليني أنزعج جدا جدا وأكون على أعصابي حتى ما أشوف البيبي. فبصراحة ما أعرف جات صدفة ولا لا إنه البريك بعد الليكشر دي بتاعتك يا أميرة. فلأنه I think it is very very difficult to understand, difficult to anticipate وفيها a lot of things يعني بتخليني confused. يعني في حالات واضحة إنها محتاجة كولينج وفي حالات واضحة إنها ما محتاجة كولينج. الحالات اللي بتكون في الجري اريا دي هي الحالات دائما يا أميرة بتعمل لنا حتى مشكلة في الان اي سي. وعشان يعني بتلقى حالة تكون ايوه في مايل ميتابوليك اسيدويس لكن يحصل لها كونفولشن على 8 اورز. فانت يباص البيريود بتاعت 6 اورز اوف كولينج فما تعرف تعمل ايه، ما تعرف تتصرف كيف. فدي واحده من المشاكل اللي بتواجهك دائما. الاكبر مشكله فيها وانت تعرضت لها اللي هي مواضيع الكونسلنج مع الفاميلي والكوميونيكيشن مع الفاميلي. فمعليش انا بقيت اتكلم من غير ما نتعرض لازياء لانه صراحه الموضوع حساس جدا وشيق ومتعب. فدي اللي بيخلينا السؤال الاول بقول لك يا اميره رول اوف اريثروبويتين ان اتش اي اي.
Yes, yeah, erythropoietin have been used as a neuroprotective, but it should not be used alone. Should be combined with hypothermia. Some centers they are using it. I use it for 2 patients. I didn't يعني see effect because those babies are severely affected. But it is tried, but it is not a standard يعني of care, and it will be like by institutional decision. But yes, it works. It has some sort of neuroprotection, especially in case of moderate to severe hypoxic ischemic encephalopathy.
زي ما قلت اميره انه هي ما ستاند اوف كير. طبعا انت اذا في عندك بيشنت ويز هايبوكسيك اسكيميك انكفالوباثي وما عملت له كولينج يعني يو هاف تو ستارت كولينج. بعد كده انت وات تو اد دي حاجه بلس اور ماينس ديبيند اون ذا سنتر. فاميره really to be honest I am using erythropoietin for all HIE patient on cooling. Really we have a good outcome before in our previous institute. Even the neurologist comment what you are doing. We notice that there is something wrong in the patient with HIE. They are doing better now. We are telling them we are start using erythropoietin 1000 international unit per kg. For this one really I believe on it. We use it. الإريثروبويتين بيعمل لنا نيوروجينيسيس. احنا بيحصل لنا ابوبتوزيس مع الاتش اي اي، بيحصل لنا سيل ديس. الإريثروبويتين one of its action بيحسن لنا النيوروجينيسيس. طيب سألونا عن التايم اوف ام ار اي يا أميرة.
Yeah, the time of MRI, yeah, the best time is يعني within the first 1 week. But يعني now even in the literature is preferably day 4, especially day 4. But you have still window up to day 7. Day 4 to 5 is the best. Yeah. And after day 7 you will have يعني there is the changes will be disappear and you will be lost.
Can I cool baby with HIE after 10 hours of delivery?
So يعني according to the recommendation no, but now there is يعني studies going on and there is some يعني cases reported they cool after the baby's past 6 hours and they have يعني good outcome. You can, but it is not like a standard of care or something recommended. It is like trial by center يعني individual practice.
I think there is trial up to 8 hours. عملوا ترايل على 8 hours وفي ترايل على temperature. نحن now we use temperature 33 to 34 some cooling for 72 hours. ففي study على 32 hours ولقوها not beneficial و longer than 72 hours and found not beneficial. So now the cooling 33 to 34 72 hours لكن after 6 hours is still not evidence based. حد بيسأل عن الديagnostic criteria.
Yeah. So diagnostic criteria, to say this baby sustained hypoxic ischemic encephalopathy, first history. So as I mentioned, the obstetrician will call you, there is no fetal heart, there is cord prolapse, so there is perinatal event. So after the baby delivered, if this baby, the cord blood gas is pH is less than 7 or base deficit equal or more than 16 or 12, or if you don't have cord blood gas, first blood gas is within the first 1 hour, preferably arterial, if no capillary or venous, with evidence of severe hypoxemia. And after that, you will assess the patient by Thompson and Sarnat scoring. The baby has evidence of encephalopathy. Sometimes there is in some literature they are telling don't let blood gas fool you. Sometimes you will have like normal blood gas or mild acidosis, but the baby clinically is very bad. So it is a syndrome. It is combination. It is laboratory and clinical. So even if you don't have blood gas, sometimes no blood gas. In case of severe abruptio placentae, no blood in the cord. And sometimes, so you have to assess also your patient clinically, diagnose him. So if you have these criteria and supported by the Thompson scoring and Sarnat scoring on your ongoing assessment, so you can label your baby as hypoxic ischemic encephalopathy. But if the course is, like sometimes the course is strange, you need to exclude the other causes of encephalopathy if the history is not clear. So sometimes you need to do metabolic screen, you need to assess the patient for other causes of neonatal encephalopathy if you don't have clear history.
بس دكتورة أميرة أنا عندي بوينت يوجوالي بعملها أو بتابعها. If you are in doubt start cooling. if you عشان ما ندخل في حتة إنه والله start convulsion after 8 hours 10 hours start to show different symptoms. But if you are in doubt to cool or not to cool, I prefer to cool so that it will be the best interest for the patient. طيب.
Yeah, for us also we are starting cooling. If you are in doubt and the baby in front of you and you think the baby can benefit, you can start
طيب the starting fluid was 50 to 60 ml per kg per day. Is it continue with the same amount at all days or add the daily need of fluid? Also, we ask about addition of calcium in the first day.
Yeah, so no fluid, this is to start with, but you have to do ongoing assessment and you need to assess your baby on daily basis and you need to increase your fluid according to the status of the patient, the urine output, the electrolyte. Sometimes, calcium is not recommended to be started from the first day, but sometimes if you have severe hypocalcemia, one time I have patient convulsed in the first day from severe hypocalcemia, so I was obligated to give calcium. So it depends. It is not like very contraindicated. It depends if the calcium is less than 1.7 or your baby symptomatic, you can add a small amount of calcium and monitor your baby.
And again, as you mentioned, really for our conditions in Sudan, if we don't have a machine for cooling or head cooling or whole body cooling, the passive cooling is doing the job. And really, in our center before, we have only passive cooling just off the warmer. خلي البيشنت مكشوف. لو احتجت بتحط cold gloves beside the baby or ice. الcold ice بتاعت الأدوية اللي بتاعت الvaccines واللي بتاع الcold دي. We keep it around the baby, even not touching the baby directly. لكن it is around the baby. It will give you the target temperature with the monitoring of rectal temperature. طيب, what about the MRI in the first day? I think it is more accurate in first hours of life.
You know, sometime if يعني like this hypoxia sustains the baby hypoxia, you have, because hypoxia can be acute, subacute, or chronic. If the baby sustain hypoxia يعني couple of time in utero after birth, immediately you might have MRI changes, and it happened يعني before in some of the babies. When we did the MRI, there is يعني almost chronic hypoxia, and even you can find cystic changes in the MRI. So this indicates this baby sustained hypoxia couple of time. We have previously يعني in my institution 2 babies. Mother has partial abruptio placentae for both babies, and they sustain in utero hypoxia, and one of them came day 3 and the other one came day 4, and these babies delivered the breast resuscitated. And later when we dig in the history, that there is decreased fetal movement couple of days, there is abruptio placentae, and MRI there is يعني severe MRI changes at that time.
بس صراحة when you did the MRI in the first day for hypoxic encephalopathy not in utero for long time, هيكون في brain edema which will mask the picture of ischemic changes. يعني I know some neurologists, they prefer that the MRI to be in day 10 so that you bypass the area of brain edema and all these things. After that, the ischemia will be ready. And the worst MRI if you have increased density in the basal ganglia or usually in the basal ganglia. That means the baby is severely affected deep down to the basal ganglia and affecting the baby. طيب, when can we give anticonvulsant prophylaxis يا أميرة?
You know, it يعني previously people used to give it prophylactic, but it is not recommended actually to give as prophylactic, because sometimes it will mask the true seizures, because you need to categorize your patient. I actually am not giving, and يعني it is like all the practice. Some people still they are giving prophylactic, but it is not recommended.
If I start when I will wean the anticonvulsant.
Yeah, usually, you know, when they are starting the anticonvulsant, if the baby discharged home, he will be discharged on oral anticonvulsant, and it will be followed for يعني 1 month to 6 weeks by the neurology, and يعني they will wean it gradually. Sometimes if the baby stayed with us like the moderate to severe, and the baby like on one anticonvulsant and يعني long time no seizures, they will wean it gradually when the patient is inpatient. And sometimes if the baby is in more than one anticonvulsant, usually they are starting phenobarb, second line they are adding Keppra, third line they are adding Tobramed. And usually from my observation, they are weaning the phenobarb and they carry with the Keppra and Tobramed, because these babies they are long term affection, and they need the anticonvulsant for long time.
أميرة, يعني we are starting, and the weaning we leave it for the neurologist. He's the one going to follow the patient later, follow the patient and see according to the opinion when it will be weaned. فنحن نبدأ هم يوقفوها بطريقتهم بعدين. قال لك if the baby develop convulsion at 24 hours and he has normal tone and active, is HIE one of the differential?
Yes, still, because when the for sure if this patient fulfill criteria of hypoxic ischemic encephalopathy, should be the first thing to think about, but you have to check the other causes like electrolyte disturbances, hypoglycemia, hypocalcemia, hypomagnesemia. If you exclude all these and you have like normal MRI and normal EEG, still you can label the patient. If you ended up by only hypoxic ischemic encephalopathy, you can label him as ischemic encephalopathy, and you need to follow him. And they need to repeat later MRI, EEG in the follow-up and to assess this patient developmentally. But I cannot exclude, if there is clear evidence of hypoxic ischemic insult, I cannot exclude the hypoxic ischemic encephalopathy, but I have to exclude the other causes.
أميرة, طبعا موضوعك معقد ومشربك جدا وشيق. What about MRI changes? This will be the last question عشان نمشي نصلي. What about MRI changes and the time to be disappear?
You know, this more of neurology. You know, first there will be يعني diffusion restriction. They will do the MRI in the diffusion weighted imaging. There will be diffusion restriction. This is in the initial MRI. And usually if you repeat the MRI after another 2 weeks or 10 days, you will see يعني the more hypoxic changes, especially in the basal ganglia and the thalamic area. So the initial one is diffusion restriction. This is the يعني mainly the neurology depends on the diffusion restriction in the first few days. Later on there will be clear يعني hypoxic insult, especially in the white matter. And the prognosis, it depends also in the area يعني affected. So the neurology look into certain area, basal ganglia, thalamus, and white matter. And prognosis depends on that one. And they will keep following these babies with MRI and EEG يعني till certain age.
Is management magnesium sulfate used in the management? يعني any role of magnesium sulfate?
Yes, it was all the practice. Previously they used to use the magnesium sulfate, but because of the toxicity, and now يعني there is other modality like cooling and other things. So يعني people away. Now no one is using magnesium sulfate, but sometimes if you are in limited resources area يعني some people still يعني in peripheries they are using magnesium sulfate.
Thank you, Dr. Amira. Thank you very much. We will have now break for 30 minutes for people to pray, taking break, coffee, and relax and relaxing their hypoxic brains. عملت لنا hypoxia أميرة.
Thank you, Dr. Ahmed. Yeah, you give me the most difficult topic. What I will do. Thank you so much.
We'll come back at 7:30 Saudi Arabia time, 6:30 Sudan